and we'll have a quick this review today for the hematology and oncology MCQs. I would like to interact with you at the end of the session. So whatever the queries you guys have, just do let me know so I can answer all your queries. Then we will pack up. We are not in hurry, but if you concentrate well, it's 100% the all queries will be solved today of most of the major topics. Those who wants to get a pen and paper, I wish you get a pen and paper so you can make some notes. As well as after the class, I will share this whole complete PowerPoint with you, so you also can revise later on. So don't worry about getting the notes. I will share completely whole PowerPoint with you. So nothing to worry. All right. So that's it. And you can chat here as well if you want to have some queries. And humble request to make your mic on the mute mode. If you want to ask something, you can unmute and interact with us. So not a problem. You can chat here as well, right? So we will do it as soon as possible. Right, yes, recording is also given to all of you. So there was one query that recording is given to all or not. So I will share the complete recording of this sessions as well. So nothing to worry. Just stay tuned and keep in touch. So let's start this session. Yes, completely clear, audible and visible.
Yes, sir. Totally સંભળાય છે.
Excellent, wonderful. So
Visible છે,
let
audible બી છે.
wonderful, wonderful. So let's start. This is the medical MCQ for all. Myself. This is the general quick review. What we do for last 10 years, almost a decade now in this field, in guiding and coaching to the students. We provide the 1000 MCQ hard copy book. We have online subscriptions and coaching. We provide WhatsApp subscription, Oman Viva coaching subscription, data flow services, short package, and mobile applications. So those who have not downloaded, they can download the mobile applications as well. So that's it. So this is what my academic experience quickly. I am clinical hematologist and oncologist, almost 20, practicing for 20 plus years in the city and out of city as well. Right, I have work experience of international. I work for Oman. I work for Kenyan Medical Board. I cracked the Australian Medical Council, and I did my bone marrow transplant training from Italy, Rome for thalassemia major and sickle cell in 2023. Sorry, 13. And we recently launched our new book, which is updated in January 24. So those who wants, just do let me know. You can directly order from the online. That's it. So this is what our team is. This is briefly our team, right? Dr. Meghna here, who is full time in the Dubai. So those who wants local help in Dubai, you call and contact Dr. Meghna. I'll share all the numbers. And if you want to take a picture, you can contact us on our website. You have our number, Pallavi's number, my number, everybody's number, and official email ID, right? So you can have all the numbers, nothing to worry. Great. And this is what the thing is briefly. Dr. Munjal, I did my fellowship in hematology, oncology, and bone marrow transplant. At least 20 years, written as a 15 years of clinical experience and treating the blood disease, cancer, and bone marrow transplant. More than 10 years of clinical experience and treated so far. The registered patient is more than 100,000 in my practice. So I definitely try to conclude complete clinical things, right? So let's begin. Get a pen and paper, concentrated here. You will 100% enjoy this session. So I don't want to give you the score, who is passed, who is failed, but every questions you write down and you know what's your answer and what's the correct answer. So you end of the day or end of the session, you know that okay, out of 30 questions or 40 questions, how much is right, how much is wrong, and you can get and assess yourself only that okay, what score you got it right, and try to concentrate, right? So first question in front of your screen, right? I'll give you 10 seconds, 15 seconds as per the exam, so you just think over it that what could be the things, and then we'll discuss. So first questions: in CLL, chronic lymphoblastic leukemia, the patient has a 13 grams of hemoglobin, white blood cell of 80,000, and lymphocyte is 80%. Peripheral smear, this is the peripheral smear. So peripheral smear shows mature looking lymphocyte. So this all blue looks lymphocyte, right? So this is lymphocyte, this is red blood cell, and very small is a platelet, right? So this is a lymphocyte. So this is classical peripheral smear. So peripheral smear shows mature looking lymphocyte. Platelet counts are 200,000 or 2 lakhs. On examination, no lymphadenopathy, no organomegaly. They're asking for what is the stage of this CLL. So you have a 5 options: stage 1, 2, 3, 4, and 0. Think over 10 seconds, right? Post your answer in the chat box as well. I would be happy, right? And then we'll discuss and write down your answer, how many correct and how many wrong end of the session, right? It's difficult for me to assess at the same time 50 people, but you can keep in mind.
आंसर भी दे रहे अच्छा देने का है क्या
I'll tell the answer, doctor. You can mute your mic, no problem. I'll share all the answers.
देख दी ना आंसर मेरे को क्या समझ रहा हूँ उसमें
Please make your mic mute, doctor, as I requested you, please. It's a humble request. Otherwise, I cannot concentrate, honestly. You have a facility to make your mic mute.
Leukemia patient has HB 13 gram, the 13 gram patient, WBC 80 gram, leukocyte is 90%, peripheral smear, short mature looking lymphocyte, platelets 2 lakhs. On examination on lymphadenopathy, no organomegaly. What is stage of CLL? Stage 1, stage 2, stage 3, stage 4, stage 0. Stage 0. बराबर है ना सब?
Yes, so just make your mic mute, please. It's a humble request again. So we will discuss all the things in detail. So now listen, this is a CLL. So this is a case of chronic lymphoblastic leukemia, right? So first of all, chronic lymphoblastic leukemia. So what is a striking feature? As the name itself suggests, chronic lymphocytic leukemia. So something there is a lymphocyte will increase. Number one. So lymphocyte is increased, total count increase. Amongst total count, lymphocyte is increased. What is the differential point in CML, chronic myeloid leukemia? The same thing, total count is increased, but in CML, neutrophil is increased. So this is myeloid series is neutrophil and lymphoid series is a lymphocyte. So this is the biggest striking features, right? If somebody says there is a 90% of neutrophil, then probably this answer may change from CLL to CML. So biggest difference in CLL and CML is that, right? In CLL, WBC count increase, CML, WBC count increase, but in CLL, lymphocyte increase, in CML, neutrophilic leukocytosis. So this is a major basic difference in CBC, right? So they have given clear cut 90% lymphocyte, right? So there are 5 stages, right? So stage 0 is what? Just the lymphocytosis, only lymphocytosis with the increased count. So increased count would be every, right, 0 to 5 or 0 to 4, all have a high count, but here only lymphocyte. Stage 1, one thing add, increase lymphocytosis, blood it from lymphocyte or blood it goes to the lymphadenopathy. So there is a cervical lymphadenopathy or lymphadenopathy in axilla or abdomen. So this is lymphocytosis plus lymphadenopathy, stage 1. Stage 2, more one thing, right? Lymphocyte increase plus hepatosplenomegaly, means organomegaly. So this is a organomegaly. Stage 3, when the lymphocytes are so much fastly increase in blood and bone marrow, right? It causes the anemia. It won't allow the other cells to grow, anemia. And fourth is a thrombocytopenia, right? So these are the 4 stages, right? One is a lymphocytosis only, right? Zero is a lymphocytosis only. One thing more added in the lymphocytosis is lymphadenopathy, hepatosplenomegaly, anemia, and thrombocytopenia. So let's go back to the questions again. Now what do you think now, right? Whatever the answer everybody has given, now probably your answer will change. So now give me the answer. What could be the answer here, right? What you can see in this patient, CLL with lymphocytosis, right? What could be the answer, right? So answer could be the stage 0, right? So it is confirmed that lots of people had given the good answer and the correct answer. So stage 0, why? Because just the lymphocytosis, let me rule out all the four stages, right? Anemia is not there. 13 grams of hemoglobin is quite good hemoglobin, obviously, right? So anemia is not there. Anemia is not there means what, right? Stage 3 is gone, right? Platelet count is normal, so stage 4 is also gone, right? And what else? There is a no lymphadenopathy. So no lymphadenopathy means stage 1 is gone. No organomegaly means hepatosplenomegaly. This is also gone. So what is remaining? Just the high count with lymphocytosis is stage 0. So answer here is a stage 0. Is that clear? Any question? Right? So this is what the answer is. Right, so this is what I had given again here: lymphocytosis, lymphadenopathy, hepatosplenomegaly, anemia, and thrombocytopenia. That's all. So this is one questions they ask you in the exam. The next question what they ask: what's the treatment of CLL? Right, so CLL usually this is the clinical tips of CLL. You must keep in mind they ask you any question. Either they ask you how you diagnose the CLL, they ask you how you investigate the CLL, they ask you how you treat the CLL. So I'm trying to club up many questions in one MCQ. So one thing we have seen the staging we are clear. Second thing is that the right. Second thing is the stage, right? Stage 0, 1, 2, 3, 4, right? What's the tip? CLL has no unique physical finding. So you can't say, oh, this is CLL, this is CML. Outside, you cannot say they looks like absolutely normal, right? And most of the time, many books is written that they can usually, I mean, incidentally detected on the routine evaluation, routine checkup. They get to know that, oh, I have a CLL. They are flying to US, they are flying to Middle East, right? And on pre-fly body checkup or some screening, they found to have, oh, platelet count, sorry, WBC count is 80,000 and new and lymphocyte is 95%, right? They diagnose as a CLL. That's it. Patient doesn't have any complaints, so there is no unique physical finding, right? And for all leukemias, this is again tip we will see in the next slide. So there is no physical finding, characteristics finding, right? And lastly, the treatment. So what is the treatment? Most of the CLL patients are asymptomatic, as I told you. So usually in stage 0, stage 1, and stage 2. Stage 0 is a lymphocytosis, lymphadenopathy, hepatosplenomegaly. They just the incidental finding, or when you stage chest X-ray, USG, you find that okay, organomegaly. So no need treatment, no treatment is required. CLL usually advanced stage means what? Either stage 4 or 5. Anemia or thrombocytopenia, they need the treatment, right? So just also keep in mind anemia and thrombocytopenia, they need a treatment for anemia and thrombocytopenia. So this is the diagnosis, this is the staging, this is a these things. Can anyone tell me what is the name of the classification of CLL? There is one name of classification of CLL. Anyone knows what's the name of classification of CLL? On someone's name, there is a classification of CLL. Anyone know? Anyone know? Speak up, no problem. Unmute and speak up. Not all together, one by one. Right? So if you don't know, that is the homework from my side. So you go and check it out. What is the classification of CLL? So go and read it. Right? So let's move to the next question. Right? Are you getting me? Yes or no?
Yes, sir.
Everything going well?
Yes,
Definitely,
sir.
sir.
Wonderful, wonderful. So let's move to the next slide. Great. So this is the second slide in front of your screen. Probably you may get sometimes the clear cut same picture in your exam. So don't ignore the pictures as well. Try to cultivate the practice of seeing the pictures, seeing the USGs, seeing the ECGs, seeing some X-rays, right? So that they may ask sometimes in spot diagnosis, and that would be the clue sometimes for your exam. So what they are saying, second questions right here. So let's go to the second question, right? What's the second question? Which is the most confirmatory test for AML? Now CLL to AML, acute myeloid leukemia or blood cancer. Arrow shows or rods in the blast. So where is the arrow shows? So let me tell you, this is the arrow here is showing, right? What is the OR rod? Let me define you OR rod. This is a cell, this is the nucleus, and around nucleus there is a one rod like structure in the cytoplasm that is called as a OR rod. So you can see clear cut OR rods in the cytoplasm. So now understand the questions, what they are asking, right? Most confirmatory test for AML, right? So you have a one patient, probably leukemia. They have given you all rods. Okay, fine. It's AML. Confirm AML is all rod is AML. I'll share you the tips. So whenever you see all rod, right? So what's the question in exam? Number one question in exam. You seen all rod. They have given long scenario, 10-line scenario, very long scenario, and they mention in last line that peripheral smear shows this, and there is a presence of OR rod. What's the diagnosis? Diagnosis is AML. Number one question in exam, right? So OR rod is equal to AML. Write down. There is no differential diagnosis of OR rod. If you see the OR rod, AML. This is not they asked here. They asked what? They are asking for the confirmatory test. So this is one question. So now you want to confirm AML, right? So what could be the confirmatory test? Bone marrow examination, flow cytometry, cytogenetic, or PCR. Get a 10 seconds for your thought process and get back to me. Don't read, doctor. I'm reading. You just mute your mic. You just post your answer in chat box. If you have questions, you unmute and ask me. But don't discuss amongst each other. It will definitely disturbing. So what I'm seeing the most of the answer, right, is the B. Somebody is saying, Varun is saying B, Usman is saying B, right? So you post your answer. No? Don't worry, right or wrong. It's a learning platform, absolutely. Because you have to answer something in the exam. You can't make it blank. And if you make it blank, unfortunately, that marks is gone. So even wrong, you post something. Wrong, it's okay, fine, don't worry. Right, so let me tell you the answer. Few people are also posting the answer very quickly, right? So there are a lot of A answer, a lot of C answer, right? Mishika is saying B answer, so that would be great, right? Right, so the again A answer. So there are lots of A answer. So let me tell you, let me clarify you the clear the picture is that, right? Let me clarify you now all the things, right? So I had given you the tips. OR rods is equal to AML. Write down in your note. AML is equal to OR rod and OR rod is equal to AML. Number one. Let me give you the more clinical tips here, right? Whenever patient comes to you, right, there are four stages. Whenever you suspect any patient has a suspected leukemia, right? So first test you do, you will not do directly bone marrow. Initial test you do in a suspected case of leukemia. Say for example, patient around 50 years male, right? Bone pain, fever, thrombocytopenia, pancytopenia, hepatosplenomegaly. So initial test would be the CBC and peripheral smear. Write down. This is number one question. Here we are discussing at least 5 questions in one. If in the exam they ask you the initial test, I think, please mute, brother, mute, please. Why don't you understand? So if they ask you the initial test, then it is a CBC. If they ask you the diagnostic test, then it is a bone marrow. If they ask you the confirmatory test, then it is a flow cytometry. And if they ask you the prognostic test, then it is a cytogenetic or cytogenetic or chromosomal analysis. That's it. So this is what the thing is. Right. Brother, can you please mute the mic, please?
Guys, please mute your mic. We can't listen this, sir. Everyone,
Brother,
please mute their mic.
So this when the patient comes to you, what the first step is a initial test. So you can't directly jump on the bone marrow, right? So initial test is a CBC and peripheral smear. So this is one question in exam. If the same questions change here, right? What is the initial test? Answer may change, right? If they says what is a diagnostic test, then answer may change. You diagnose by the bone marrow. You are not confirming by the bone marrow, right? By doing the bone marrow, you diagnose that, okay, this is acute leukemia, this is chronic leukemia, this is this type of leukemia. So this is a diagnostic test. Let me tell you, diagnostic test. So bone marrow examination is a diagnostic test. So those who have given answer here, the confirmatory test, bone marrow is a wrong answer. It's a diagnostic test. How you confirm, right? So first initial test, as I told you, CBC peripheral smear. On the suspected basis, from initial test you go for the diagnostic test, that is the bone marrow. Once you do the bone marrow, you see some kind of blast or some kind of OR rods, but you need to confirm then most confirmatory test across the globe is a flow cytometry. What is a flow cytometry? You must have heard the CD marker. On every cell, there is a cluster differentiation, CD marker. You must have heard CD134, CD20, CD128, blah, blah, right? There are long list. So this cluster differentiation, which present on the cells of the leukemic cell or WBC cell, that exactly defined whether it is a myeloid or lymphoid. So confirmatory test is a myeloid or lymphoid. So this is how you confirm. And fourth test, very important, is a prognostic test. What do you mean by prognostic test in leukemia? So prognostic test, by doing the cytogenetic and chromosomal analysis, you get to know that what kind of chromosomal abnormalities are there or what kind of bad genes are there. And depends on that, international guideline comes and that differentiate, right, various leukemias in a prognostic factor, like a low risk, right? If I can say, there are three main category in general: low risk, intermediate risk, and high risk, right? So low risk, intermediate risk, and high risk, right? So these are the three category. So that comes in the come on, yeah. Can you explain this, guys? I really irritating. So right, so this is the prognostic test. There is a three prognostic test: low risk, intermediate risk, and high risk, right? So you got the idea, right, what I'm trying to explain, right? So you need to completely look into the scenario what they exactly ask, right? So let's go back to the question again: which is the most confirmatory test for acute myeloid leukemia, right? So probably now your answer is changed and it is now flow cytometry. Any leukemia, if you want to confirm 100%, do the flow cytometry. Flow cytometry is absolutely a diagnostic this confirmatory test. So these are the few steps I had given. If they ask you the initial test, this is the tips for acute leukemia for you guys, right? So if they ask you, okay, what is the initial test, right, then you can tick the initial test is a CBC and peripheral smear. Diagnostic test is bone marrow examination. Confirmatory is flow cytometry, and prognostic is a cytogenetic. Another name is a chromosomal analysis, where we see one chart, right, where 1 to 23 pairs of chromosome is given. This whole complete chart, 23 pairs of picture, it is called as a cytogenetic or chromosomal analysis, right? So that gives you what genes, what chromosome affected, right? So that decide the prognosis, how bad or how good they behave down the line after treatment. So you need to confirm the things, right? You need to diagnose the leukemia, you need to confirm the leukemia, and you must know what is the prognosis by doing the chromosomal analysis or by test. So without this four test, I never going to treat any patient, right? This is how the flow goes in the clinical practice. Is that clear, everyone? Is that clear,
Yes, sir.
everyone? Yes or no?
Yes, sir. Yes, sir. Clear.
Wonderful.
Yes, sir.
Any
And sir, can you please remove those who can't keep their mic mute
No, hopefully
from
now
the meeting?
they will hopefully mute now. Anyway, so any questions from the audience quickly? I can give 15 seconds right away. Any quick questions from the audience? Fair enough. So no question means I think I'm clear, right? So few other, yes, please.
Sir, what about CML and
That will come. That will come in next slide. That will come. About acute leukemia, do you have any query so far what I explained you, right? So that's fine. Little go ahead, right? You write down your questions. I will sort out, right? So this is the tips. This is tips means there are again a 7-8 questions MCQ. This is 7-8 MCQs in your exam, either DHA, HAD, MOH, or OMSB. Number one, what is the definition of acute leukemia? How you differentiate acute leukemia and chronic leukemia? Basic, right? So any leukemia who has more than 20% of the blast in blood or bone marrow is acute leukemia, right? Acute leukemia, 20% blast. So 20% blast in blood or bone marrow is acute leukemia. That's it. Chronic leukemia, right? So doesn't have the blast. They usually have blast less than 5%. Usually, acute leukemia, 20% blast, right? So this is how you know. And this 20% blast, either if it is a myeloid blast, you call it as a AML. If it is a lymphoid blast, you call it ALL. That's it. No need to mug up. How you differentiate AML, ALL? First, look at the blast. It is more than 20%, right? If it is a lymphoid blast, it's ALL. If it is myeloid blast, it's AML. How you know the myeloid blast or lymphoid blast? right? That is a flow cytometry, confirmatory test. Flow cytometry, if you do, it will CD cluster differentiation markers on the cells of WBC, they find out and they differentiate. This is myeloid series, this is lymphoid series. That's it. So this is what the thing is. So this is not your job to differentiate AML, ALL. But if you see or rods, in the cytoplasm, whatever that comes in flow cytometry, it is AML. That's it. That is the clue point, right? And that's what they ask in exam. So this is number one tip. Second tips I already given you, right? Flow cytometry is a confirmatory test, as I told you, right? And it is preferably done from the bone marrow. But bone marrow, if it is sometime dry tap, you cannot get any aspirate from bone marrow, then it can be sent from the peripheral blood smear, especially when there is a lot of blast cell in the peripheral blood, right? If patient is reluctant, patient refusing for bone marrow, you can send the peripheral smear, the flow cytometry, right? So this is one question, acute leukemia, flow cytometry. Third, AML, how many subtype of AML? So AML has M0, right, undifferentiated to M7. There are M0, 1, 2, 3, 4, 5, 6, 7. So M0 to M7 is a subtype. Amongst another question in exam, this amongst all subtype in AML, which has a best prognosis? Answer is M3. AML M3 has a best prognosis, and it is also known as a APML, acute promyelocytic leukemia. APML, acute promyelocytic leukemia. This is another question in exam, right? So AML M3 has a best prognosis. Next question, what is the commonest presentation of AML M3 or acute promyelocytic leukemia? Exam question, DIC, disseminated intravascular coagulation is the most commonest presentation. Is another question in exam, different, right? What is the treatment of the AML? So treatment of AML is mainly the chemotherapy, and in relapse case, you go for allogenic bone marrow transplantation. Another question in exam, what is the treatment of M0 to M7? What is the treatment of M0 to M7? So all the M0 to M7, the treatment is the same. Chemotherapy is the treatment of choice, but only AML M3, acute promyelocytic leukemia, along with the chemotherapy, you add one drug called as ATRA, all trans retinoic acid, along with arsenic is a chemotherapy, and ATRA is all trans retinoic acid. It is a vitamin A derivatives which is added in the treatment of AML, especially in the M3. Otherwise, M0 to M7, all the treatment same. You give the induction. Those who worked in a leukemia ward or some ICU or some hematology setup, you say as an induction chemotherapy or 7+3 chemotherapy, where you give daunorubicin and cytarabine. So not going much in detail of that part, right? So, and all acute leukemia are curable disease, definitely. So don't give the wrong message to the patient when you have acute leukemia. Oh, come on, this is a blood cancer. Now it's not treatable. Patient will die. Don't do the loose statement. It is absolutely treatable and curable. In 20 years, I treated many leukemia, and I know many patients who are absolutely fine end up the 5 years, 10 years, and they are cured of leukemia, acute leukemia. So just it's a take home very good
मेरी क्लास
message.
चालू है मुंजाल सर
Yeah, please make your mic mute, brother. Right. So this is all the questions. Right. This is all the questions comes in the exam. So I, in one slide, I try to compile lots of questions, right, for the leukemias. Is there any quick questions? Got it. Everyone understood well, right? Any question?
یه ساعت بنیشت آخره و شرکت بین بپرسن بنیشت البته پتو بابوشن ارچه هاتیه بیشتی نساری
Great. So let's go to the next question.
صندلی اولینال تکسوکی
Yes. Next question, please.
یار بردم میروسه بچ بنیشن
Yes, concentrate on the question number 3. A young 32 pure vegetarian busy businessman, history of skipping the meals, right? Due to his busy schedule, he presented with history of fatigue, occasionally dyspnea on exertion, weight loss of 2 kg to 3 kgs. He has no history. How do we mute? Pallavi, are you there?
Sir, I think there is an option in which you can mute everyone else.
Where is that option, brother? These guys are very crazy. They can't understand. They can't
હેલો
listen. પલ્લવી આમાં મ્યુટ ક્યાં છે?
એટલે યોર સેલ્ફ મ્યુટ કરવું છે સર?
No, no, I have a lot of disturbance in background. I can't concentrate on my topic.
મ્યુટ ઓલ.
These guys are very crazy. They can't understand. Repeatedly, we are saying just make a mic your mute. Anyway, just look for it, Pallavi.
Just a minute. Ha ha.
No problem. So let's go to the questions. So 32 years pure vegetarian, busy businessman, skipping the meals due to work schedule. Right? He has a fatigue and dyspnea on exertion. Right? He has a weight loss of 2 to 3 kg, no history of fever or bleeding, and there is a pallor, mild icterus. Rest of the examination is essentially normal. Right?
Sir.
His blood workup, yes.
તમારું જે માઇક છે ને ત્યાં સાઈડમાં એની જ સાઈડમાં એક અપ સાઈડ એરો છે, ત્યાં જો તો ઓપ્શન આવે છે તમને મ્યુટ ઓલ.
I'll check, no problem. Let me
હા હા,
finish
yes
the
sir.
question.
સર મ્યુટ સેટિંગમાં આવશે, મ્યુટ મીટિંગ સેટિંગ્સમાં આવશે કદાચ મ્યુટ ઓલ નું.
Fair enough. Let me check. I'm not very excellent. Anyway, so just move on to the question. So hemoglobin is 7, MCV is 130, WBC is 3,700, and platelet counts are 100,000. And peripheral smear shows this, right? So you can see the peripheral smear. This is absolutely a peripheral smear, right? So you need to understand where is the peripheral smear. So peripheral smear looks like this. Now they ask you the diagnosis. What's the diagnosis? Is it iron deficiency, hemolytic anemia, megaloblastic, or blood loss anemia? Think over it for 10 seconds and give me the answer. It's a very easy question. It's not very tricky. If you know the basic things, you can answer very easily. Give it a thought for 10 seconds. Don't be in a hurry to give the answer, and try to understand the logic why you have selected this answer. You understand?
Będzie na to nasadę, a bardzo słusznie jeszcze nie widzę. To na hasztag będzie. Bo łatwiej, jeszcze nie poruszy. Jeszcze nie wiem, ale wtedy no tym dość niż ty dość tam no robi. Ja muszę mieć.
Yes.
Okay, I thought joke that.
Yes, so all ready. So basically this is the C. So I'm not going in much detail. So most of the answers are correct. Let me give you the real idea how you select the megaloblastic anemia. So first of all, the classical history. History is very, very classical here in this case, right? So what's the classical history? Vegetarian. So pure vegetarian, usually vegans are more prone to develop the B12 deficiency or megaloblastic. Number one. Number two, he is a skipping meal, so he's not eating well, obviously, right? And because of anemia, he has a fatigue. Because of anemia, he has a dyspnea on exertion. He has a weight loss. He has no fever, right? So you are not thinking of leukemia. Leukemia usually have three symptoms: fever because of low or high WBC count. They have bleeding because of low platelet, right? So they are not saying anything, right? So no fever, no bleeding. So not much thinking of leukemia. They have pallor. Why? Because the platelet counts are low. Why the mild icterus? Because of the hemolysis, ineffective hemolysis in megaloblastic. They have mild icterus, right? So hemoglobin is 7, obviously. WMCV is very, very high. Let me tell you, the normal MCV is 80 to 100. I will come on that excellent point. Femtoliter, this is a MCV, right? So MCV is high, not high, very, very high, 130, right? And WBC platelets low. So how is the picture? He is a vegetarian. He has a pancytopenia. Why pancytopenia? Anemia, leukopenia, thrombocytopenia. So pancytopenia and excellent features which you need not to I mean, if you don't read or if you don't know anything, if you know this, you can answer. Hypersegmented neutrophil. So where is the hypersegmented? In the peripheral smear, you can see the hypersegmented. Again, what is the definition of hypersegmented neutrophil? So anything more than 5 lobes in the neutrophil, it is called as a hypersegmented, right? So this is neutrophil. I'll drop for your knowledge. Probably you seen it in the physiology in the medical graduate. So this is how the neutrophil looks like. And neutrophil means there is a granule. So a granulocyte and granulocyte. So this is granulocyte. right? So if you have 3, minimum and maximum 5, this is normal neutrophil. Anything 5 lobes in neutrophil is hypersegmented. Let me count. 1, 2, 3, 4, 5, 6, 7, 8, 9 probably. So it's a hypersegmented. And hypersegmented neutrophil when you comes, right, B12 or folate, no other differential diagnosis. Hypersegmented neutrophil, right, close your eye and tick the B12 folate. That's it, right? This is a classical case. So nothing is like, I mean, this is a, I mean, most easiest question. They give all the clues of B12 and this is what and how the present in clinic. I see in my day-to-day practice, busy businessman, not eating well, vegans, pancytopenia, high MCV and hypersegmented neutrophil. Classical picture. So no need to think. Now I will educate you more about this. Why others are not there, right? That is also important. You need to exclude. Why iron deficiency is not the answer? Let me tell you quickly. Iron deficiency is not the answer because what point against iron deficiency? Number one, first and foremost is the MCV. In iron deficiency anemia, MCV is low. First, before that, you should know what is normal MCV. So 80 to 100 is a normal. In iron deficiency anemia, there is a less than 80 MCV and in B12 folate or megaloblastic more than 100. So this is the simple clue. If you remember this, you can diagnose. That's it, right? And right, and in iron deficiency, this is one point against iron deficiency. Why? Because MCV is very high. Second point, in iron deficiency, you never ever get pancytopenia. You never get. In iron deficiency, you just get low HB. Hemoglobin is 7, WBC is 4,000, platelet is 200,000. Means WBC platelet is normal, only hemoglobin is low. That is iron deficiency. Here you can see all the 3 low. Hemoglobin, white cell, platelet. So it's not iron deficiency. Third point against iron deficiency, you cannot see hypersegmented neutrophil. You see hypochromic microcytic. RBCs are small and there is a reduced chromatin in the RBC. That is called hypochromic microcytic. Microcytic, micro means small, cytic means size. So small size of RBC you can see, and whatever RBC you see, there is a central pallor too much. There is a less chromatin. That is why it is called microcytic hypochromic. Right? So it is nothing matching iron deficiency. So it is gone. Is that clear? Yes or no? Be with me. Is that clear?
Yes, sir. Yes, sir.
Wonderful. So iron deficiency is gone, right? Why it is not hemolytic anemia? What you can see in hemolytic anemia? Again, hemolytic anemia, there is only anemia, no pancytopenia. So that is again number 2. In hemolytic anemia, there is a hemolysis, means low HB as well as increased bilirubin, which is not there. There is an increased LDH, which is not there. There is increased indirect bilirubin, which is not there in the scenario, means it is not there, right? And there is nothing suggestive of hemolysis in this exam. I mean, questions, right? There is no history of drug, no history of infection, no history of pneumococcal, no history of prosthetic valve in the blood, no history of DIC, no history of blah, blah, right? So there is nothing suggestive of hemolysis. So that is gone. And blood loss anemia, why not? Because there is nothing, no history. And when there is a hemolytic anemia, the biggest thing is the retic count. If you know the basic, when HB low, when there is a hemolysis of the blood, the feedback mechanism retic count should increase. And there is nothing mentioned about retic count. That is against the picture. Again, in blood loss anemia, you will not get the hypersegmented. Again, in blood loss anemia, you just see the anemia, not the leukopenia and thrombocytopenia. So I think it is very clear cut from my side. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
So this is how you have to differentiate as well. You can't just go on the switch on the that okay fine. They may little change the scenarios, right? So you need to know the logic why this and why this not. So I just try to explain you properly that why this is the only answer and why not A, why not B, why not D. That is also I explained because of this A, B and D is excluded, right? So this is what the thing is. So let me go to the next slide quickly. So I already explained you everything and I'll share the slide with you. Newborn.
I have a question.
Yes, please ask.
For iron deficiency anemia and blood loss anemia, what's the difference mainly? Because I can have iron deficiency with blood loss, right?
Yes, true. That's correct.
So how can I differentiate it?
I'll tell you. Good question. Iron deficiency anemia is a broader term, right? Now see, think of the iron deficiency anemia. What causes iron deficiency anemia? One is a reduced intake. If you don't eat at all iron, you will get iron deficiency. Second thing is absorption problem, right? You are eating well, but you have Crohn's disease. You have some celiac disease. Iron is not get absorbed. Another thing is a this right absorption problem. Third problem, and also a pernicious anemia. Have you heard of pernicious anemia? Pernicious, where intestinal villi is an intrinsic factor and all not getting. So one is oral problem, one is a absorption problem, third is a blood loss problem, right? Blood loss is how blood bleeding blood rectum. Somebody is a heavy menses in the female, right? Menorrhagia. Another is a right major road traffic accident and massive blood loss where you lost the blood and HB is reduced, right? And fourth is a pregnancy. Also, you get in pregnancy dilutional anemia. So by the history, you should know, right? How you differentiate. So iron deficiency is a broad umbrella, right? But iron deficiency is due to poor oral intake. Iron deficiency is because of intestinal problem. Iron deficiency is because of blood loss, or it's because of pregnancy or some other reasons, physiological reason. Is that clear? So whenever you think of blood loss or iron deficiency anemia, there must be some history of blood loss, right? There is nothing like blood loss here in the history, right? And in blood loss anemia, you cannot see the pancytopenia, number one. In blood loss anemia, you cannot see the hypersegmented neutrophil. In blood loss anemia, right, there must be some history of bloodless, na? So there is nothing in these scenarios. Is that clear to you, doctor?
Yes, doctor, thank you.
No worries. Fine. So that's great. That's a good questions. I'm glad at least you are asking me the questions. Those who ask, they like me more. Question number 4. A newborn baby presented with the profuse bleeding from the umbilical stump after the birth. Activated partial thromboplastin time and prothrombin times are normal. What is the most likely probable diagnosis? Factor 13 deficiency, von Willebrand factor deficiency, factor 12 deficiency, or Glanzmann's thrombasthenia. So let's see. The answers are coming pop up. A, Amal is A, Saima is A, Manan is A, Sonal is A. Just think of it. This all question comes in exam. So don't, I mean, you need to answer, right? So, well, Midila is A, Zafarnisa Begum is A, Midila Gopinath is A. Fair enough. Fair enough. Nadine Diab is B. Why, doctor, you selected the B answer? Anyone? Dr. Vijay M, you selected the B answer. So what do you think? What do you think of the von Willebrand disease in this condition? Dr. Vijay M, somebody, Dr. Vijay M. If you are not shy to speak to me, you can speak. Dr. Varu, you posted.
Doctor,
Yes, please. Who
yeah,
is
I
this?
also answered B.
What's your answer?
I also answered B, von
What's your
Willebrand.
good name, doctor? Sorry.
Nadine.
Nadine. Okay, so I'm just trying to understand. See, this is a learning platform. So what makes you in your mind that this is von Willebrand factor? Tell me. Some points are in favor of von Willebrand disease in this scenario.
PTT and PT are normal, so I have cancelled out the factor deficiency. And because he's having a profuse bleeding, so there's no platelets. So I'm assuming that there's a problem with the clotting with the platelets. And von Willebrand, it's a platelet problem.
Yeah, but there must be some platelet functions disorder or platelet numbers disorder, right? Here the CBC is not given. That means normal. Just for your knowledge, if something is not given, it's normal. So here I can say CBC is normal, or FBS, full blood count or complete blood count is normal. This baby has HB of 13 gram, total count of 7,000 and platelet is 300,000. So this is normal, right? Now tell me, is your answer would be the same or it may change? It not mentioned means normal. Vitals not normal means normal. Temperature not mentioned means normal. Urine output not mentioned means normal. So this is a clue for you to understand if anything is not given in the exam MCQ, any exam, considered it is normal. Only tricky points and only clue points is also only given in exam. Yes, anyone else wants to try? Those who especially considered that this is a von Willebrand disease. So I want to understand what makes in your mind it is a von Willebrand disease. Just discussion. Don't worry, right or wrong. Discussion. Right. So Dr. Usman, you also posted Glanzmann's thrombasthenia. So what is Glanzmann's thrombasthenia? Why you thought of Dr. Usman? You also posted Glanzmann's thrombasthenia. So what do you think? And what is it exactly Glanzmann's? Dr. Vijay, you posted von Willebrand disease. Anyway, so I think you guys are shy to me. No problem. Let me discuss. So this is not a von Willebrand disease. Number one, right? There is a questions about von Willebrand. See, the clue is what? Clue is what in these questions? Newborn, right? This is a newborn. Newborn just born, right? And this just newborn present with the profuse bleeding. Newborn present with the profuse bleeding from the umbilical stump, right? After birth. So immediately after birth, he has a profuse bleeding, right? And his APTT and PTs are normal. What happens usually in a von Willebrand disease? Let me tell you a little bit. So von Willebrand disease, VWD or von Willebrand disease. Let me have a little good marker. So von Willebrand disease, right? It's a disease when there is a von Willebrand factor in the plasma. So first understand the basic of clot, or when there is a bleeding, clot or bleeding problem. What's you never thought of these things, what I'm going to tell you. There is a primary hemostasis, there is a secondary hemostasis. Primary hemostasis is driven by the platelet. Secondary is by the clotting factors, right? And von Willebrand disease is part of it. Von Willebrand factor, right? So platelet type of bleeding and factor type of bleeding, right? Let me tell you very clear cut differential point between this. Write down. You will not see in any books, believe me, right? This is all comes from the practical. So platelet kind of bleeding and factor kind of bleeding. Platelet kind of bleeding is primary bleeding. This is called as a secondary bleeding, right? So platelet kind of bleeding, how the patient present of platelet kind of bleeding? Mucosal bleeding. If you remember this, now you can answer any bleeding questions. Believe me, mucosal bleeding. Mucosal bleeding is meant bleeding from where? It is from the nose. It is from the buccal mucosa. It is hematuria. It is heavy menses. Blah blah. This is how the history present. Boy presented with gum bleeding, right? Lady presented with the excessive menorrhagia or bleeding, right? This is a platelet kind of bleeding. And here in the factor bleeding is what? Factor 8, hemophilia A, right? There is a bleeding in the joint that is called as a hemarthrosis. Factor 9, bleeding, right? So either it is in the joint, it is in the deep tissue, it is in the connective tissue, it is the intra-abdominal bleeding. It is all factor related bleeding. So this is absolutely given in the history, right? Blah 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 presented with the massive intra-abdominal bleeding. So it's never a much less likely it's a platelet bleeding. This is a presentation, platelet bleeding, this is factor bleeding. Number two, platelet bleeding is because of two reasons. The name itself suggests no need to mug up. What is platelet bleeding? Platelet has a two problem. One is a number problem or quality problem. Quantity problem. Quantity is number 1, 2, 3, 4 is quantity, right? And quality problem, right? So quantity problem, right? Quantity is less. Normal platelet is 150,000 to 450,000. If it is less, right? Quantity is less. We call it as a thrombocytopenia. So when platelets are low, you get a bleeding. When platelets are normal, but the quality of platelet is bad, right? Like Glanzmann's thrombasthenia is a platelet functions disorder, and quality is a function basically. This function is not normal. So Glanzmann's Bernard-Shawley syndrome. These all are the platelet functions disorder, where if you see platelets are 200,000, but patient is bleeding. Why? Platelets are normal, but they are not adhering, right? This is a vessel. This is the endothelium, right? So what happens when there is endothelial injury? Platelet, factor, and von Willebrand all comes together and make a clot. And if anything is missing, platelet is missing, clot will not form. Von Willebrand factor missing, clot will not form. Factor is missing, clot will not form. So there are three ways you can have a bleeding in your body, either platelet problem, factor problem, von Willebrand factor problem, right? So this is a basic things of this, right? And in here, if you can see, doctor, the platelet counts are normal, right? Not mentioned means normal, right? I told you not mentioned means normal. So here they have not mentioned means platelets counts are normal. And what happens in von Willebrand disease? Von Willebrand disease is a platelet kind of thing. So here you get a normal platelet in von Willebrand disease usually, but this von Willebrand factor carries, right, factor 8. So PTT is usually high. PTT is usually high. Bleeding time is also little high in von Willebrand disease, right? Which is not there in this scenario. If you can see, APTT is normal. They have mentioned normal. PT is normal, right? So this is something the anatomical or factor. So von Willebrand disease is not there. I told you why, because PTT is usually high in von Willebrand disease, right? And this is not the presentation, never present in newborn, right? Factor 12 deficiency is not common. This is a platelet functions disorder. So factor 13, or the another name of factor 13 is a clot stabilizing factor. Clot stabilizing factor. And factor 13 is the most commonest things, right? And another is a vitamin K deficiency. They also present like this as well, right? Hemorrhagic disease of newborn. Have you heard of this term? Hemorrhagic disease of newborn, or not heard? Right? So if you have not read, go and read it. Hemorrhagic disease of newborn. So this is a newborn bleeding, and this is a factor 13 deficiency. The symptoms and the severity of the factor 13 deficiency can vary from one person to another person. However, most of the patient, means 80% bleeding symptoms appears after birth with bleeding from umbilical stump being the most common. So this is what I want to convey the message. This is the classical presentation of factor 13 deficiency. So just keep in mind, they may confuse you, they may misguide you. Next questions. Any questions here? Or at the end, I guess.
Hello?
Am I going? Yes.
Yes, sir.
Sir, can you please explain the difference between PT, APTT, INR and also? I have some confusion regarding that.
If you want, if you don't mind, can you write down these questions? Let me finish this and I'll completely clear the intrinsic and extrinsic pathway which you never understood in whole your life. I will make you clear cut in 2-3 minutes, but end of the session. Is that okay with you?
Yeah, sure, sir. Thank you.
Right? So just keep in mind, I will not leave the meeting before explaining your queries. Right? So next question. Whatever, anybody has any questions, please write down. End of the session, we will go quickly. Right? Try to solve the queries. Again, interesting, frequently asked question in exam. Hemoglobin electrophoresis is done for a young adult male patients. HbA is 58%, HbS is 35%, HbA2 is 2%, and HbF is a 5%. What is the most likely diagnosis? Is it thal minor, thal major, sickle cell trait, sickle cell anemia, or sickle cell thalassemia? Combination of both. So let's see. Yeah, you think over it, that what you could think. And this is the basic questions, but you need to know what is a normal hemoglobin electrophoresis. So if you don't know the normal hemoglobin electrophoresis, this looks like a tough questions. Dr. Iram Saba, if you don't mind, can you little bit explain? You posted the answer D, and D is a sickle cell anemia. I want to understand from you, Dr. Iram. If you can unmute your mic and little speak 1 minute.
Sir, actually, I can't explain it properly, but you can say that I have the rectification because I read this question
Wonderful.
from
Sometimes
thousands
ratta
of
may
videos.
works, don't worry. And the good news in DHA is that they won't ask you the logic. They need just ABCD. That's it. So if you don't
Sir, I
understand,
have very short time.
no
So I
problem.
just
No problem. I'm just trying to understand. Don't take it otherwise. Huh? Just
okay.
trying to understand. No, but after 2 minutes, your concept will be clear and you can answer any hemoglobinopathies. No need to be doing rattafying. Forget about rattafying.
Hope
It's a
so, sir. I'm enjoying this session.
excellent. I'm enjoying more than you. You must be seeing that anyway. No worries. Excellent. Now come to the basic and then we'll again come to the question. Let me change little color so my mood will change. Normal. Sickle cell trait, sickle cell disease, thalassemia minor and thalassemia major. This is the things they ask you in exam. Before jumping any abnormal, hemoglobin, shortly I called as or book called as HBEP means hemoglobin electrophoresis. So basically no need to ratify. This is the slide, right? On the when you put a hemoglobin and pass the electrical the conduction, that is why it is called hemoglobin electrophoresis, something with the electrical activity. So they generate a band at the various stage of the slides, and this is called, and this is how we diagnose, right? So normal is what? There are in adult, there are three hemoglobin for your knowledge: A2, and F. If you understand this slide, you can answer any hemoglobinopathy. Here it is 95 to 98% normal. In adult, we are talking about adult hemoglobin because in scenario it is adult. A2 is a 2 to 5%. This is in percent, this is in percent, and F is less than 2%. Right? If you calculate 95, 2 and 5, total is 100%, obviously nothing more than 100%. Got it? So this normal, A stands for adult, minor adult, and fetal hemoglobin. So if I do my Dr. Munjal's hemoglobin electrophoresis, if it is done, it looks like this, range like this. It could be 96, 97, 98. A2 could be 2, 3, 4, 5%. F is less than 2. This is normal, right? Now, no need to ratify again, right? Understand the logic. Sickle cell trait. And what is HbS in normal hemoglobin electrophoresis? 0%. Zero. Absolutely. You cannot see even a single cell which is sickle shaped in your peripheral smear in a normal individual. It's a 0. Now, sickle cell trait. So, something is there with the sickle. So, HbS is high, obviously, simply because it's a now it's sickle coming. Na? So, there must be some sickling in the hemoglobin electrophoresis. So, how much is the sickling? If it is 20 to 40%, it is a sickle cell trait. That's it. Forget about these three part. They are all, if it is a 30%, say for example, HbS is 30%, what does it mean? Rest of all the three is a 70%. You need to have a calculation of 100%. You cannot have 101% hemoglobin, maximum 100%. We got 100% mark, not 110% mark, 100% maximum. Here, the sickle cell trait and disease difference is anything more than 40% of HbS. It could be 50, it could be 60, it could be 70, it could be 80, it could be 90. Higher the HbS, bad the hemoglobin. Higher the hemoglobin, sickle hemoglobin, bad the clinical presentation. Higher the HbS, bad the complication, priapism, vaso-occlusive disease, acute pulmonary, acute chest syndrome, right? Venous ulcer, blah, blah. You go and read it, right? So here more than 40%. What do you mean by more than 40%? Say for example, this is 50%. So all three is a 50%, total 100%. Simple. So diagnosis is done after this slide. Thalassemia minor. Thalassemia minor, something wrong. So here wrong with the, in sickle there is a wrong with HbS, not wrong with the HbA2NF. Only problem is in HbF, right? Forget about now HbS because this is a thalassemia minor, nothing to do with the sickle. So this is 0%, zero, absolutely, because we are not talking about sickle now. We are talking about thalassemia. Thalassemia have two variety, alpha thalassemia, beta thalassemia, and within beta 7, it's a whole half day lecture of thalassemia. So I'm not going in detail, right? As I did my transplant training in thalassemia, so I have a lot to speak, but I'll going with the MCQ based night, right? So in thalassemia minor, HbS is 0%. Minor, only problem in A2. A2, minor. Minor means this is minor adult, this is major adult, but it is not written M here. HbAM is not written, but keep in mind, It's a major adult, minor adult. So something minor means minor problem in a minor, A2. So instead of 5%, as I told you, maximum 5%, it could be a 10%. That's it, not more than 10. Usually, what does it mean? These two guys are 90%, total 100%. And major is what? Problem in hemoglobin F. So HbF is increased. HbA2 is normal. HB, 1 minute. HbA is low. So here in major, HbF is increased. So in adult, you must see 80%, 90%, 95% of HbF is high, right? And rest of this two is 10%. If it is 90%, it's 10%. If it is 80%, it's 20%. That's it. So you need to remember the normal hemoglobin electrophoresis, then look for the three things. HbF is, first of all, if you want to diagnose sickle cell trait or disease, HbF is present or absent. If it is zero, forget about sickle trait or disease. Why? Because HbS is zero. If HbS is there, sickle there, then you need to answer yourself what is the amount, what is the quantity of the sickling, right? So out of 100 cell, if it is less than 40 cell, it is trait. Out of 100 RBC, it is more than 40 in a peripheral smear. You see, even you can diagnose, oh, this is sickle cell. Out of 50 RBC, you can see 40 is a sickle. So it's a sickle cell disease. Simple peripheral smear. We are talking about hemoglobin electrophoresis, which exactly quantify the amount of the hemoglobin of sickle or A or A2 or F. That's it. So this is done from my side. Now let's go back to the original slide. Again, re-revise your answer. Hemoglobin electrophoresis done for an adult, right? This is, we are talking about adults. So keep in mind the normal hemoglobinopathies. HbA is a 58%, S is 35%, A is a this, and F is this. So let me again reframe this: A, A2, F, and S. So here S is a 35%, right? HbF is a 5%, A2 is a 2%, and A is a 58%. So 58 and 2, 60, 65. So this is 65% of hemoglobin, and this is 35%. So it is total 100%. All calculation match, but HbS is usually a 0 in peripheral smear or hemoglobin electrophoresis. And if it is less than 40% of HbS, it is sickle cell trait. If it is a more than 40%, you can call it as a sickle cell disease. So now what do you think? What would be the answer? Why it is not minor? Again, rule out everyone. Why it is not minor? Why it is not minor? Because A2 is normal, so minor is gone. Why it is not major? Because HbF is more than 90%, 80-90%. Here it is rather low. So major is gone. Sickle cell thalassemia means you should have HbS plus increase A2, minor component. Both, the combination of both, which is not there. A2 is normal. So this is gone. You are just confused between two, trait or anemia. Less than 40% trait, more than 40% disease or anemia. That's it. Now open for discussion. I try my level best to simplify it. Any question?
Thank you. Thank you. You have cleared my concepts.
Yes, sir. Very excellent.
So what is option C? Sorry, E, sickle cell thalassemia.
No, sir. It's a C, sir. Sickle cell trait, because it
No,
is
no.
less than.
I'm just asking because it's a combination of sickle cell and thalassemia. So
Yeah,
what is
sickle
exactly
cell.
sickle cell thalassemia?
Yeah, that I'll explain already, but still I'll give you one more minute. Sickle and thal, both the things are there. So there must be some component of HbS should be there, right? In the hemoglobin electrophoresis, any percentage, right? And thalassemia means there must be some A2 is also increased. Got it?
Yes, yes.
Right? So A2 here is normal, 2 to 5%. I already told you, if you remember my next slide, right? This 2 to 5% is a normal. This is normal. So it is not sickle thal. Is that clear? If the
Yes,
same scenario, when the sickle cell is answered, let me tell you that as well, one more minute. If this scenario says that, okay, fine, this patient has same scenario, but instead of this A2, this is a 10%. Rest of the thing is same. Then it could be answer is a sickle cell, because A2 is increased and this is less than 40%, but it is also increased. So it is a sickle trait with thal minor. Is that clear?
right, sir. Thank you. Thank you. Yes.
Anyone? Is it clear now? Where is the Dr. Rattofai? So do you think now you need to ratify this chart? You can take a picture. It's not in any book, but I try to simplify it by my clinical experience. This is the most easiest way by my sense. Is all clear? So that's it. If you are not speaking means all clear. Excellent. So this is normal, right? Here you can see A2, F and A. Now trait. Now this is excellent picture. I got it, huh? Excellent picture. So first I told you the normal, right? So without normal, you never ever get to know the abnormal, any condition. If you know the normal ECG, then you know what is STA segment elevation, right? Normal is this. Now in trait, what increase? A2. So can you see the band here is increased little? Here the thin band, here thick band. Major what problem in hemoglobin F? So if you see the F is increased. The rest of the things don't concentrate. Concentrate on the main thing. Sickle cell trait, see the smaller band, right? And this is thicker band. Means this is less than 40%. Probably this is more than 40%. That's it. This is very simple. That's it. Got it. So I'll share the PowerPoint with you. Don't worry. Everyone, each and everyone will get this same PowerPoint. So not going in much detail. This is all I'll explain to you, and this is all presented on the format. I need one homework from my side. You also, sickle is a very hot favorite topic in the exam. So what you need to know and what you need to do in sickle cell, everybody will write down how you diagnose the sickle cell, right? What is the presentation of sickle cell? Third thing is the treatment of sickle cell, very, very important. And let me tell you, I practice in Middle East for 3-4 years. I seen a lot of sickle cell, lot of things. So very much high incidence and prevalence in Middle East. So you must know in your OPD, definitely you get a sickler, right? So you must know treatment as well. And right, so these are the few common questions, right? Can anyone tell me, right, when there is a sickle cell disease and there is a autosplenectomy, right? Because of chronic infection, spleen gets destroyed. There are 3 vaccines which we need to give to the patients. Can anyone tell me 3 vaccines name? 1, 2, 3. Exam question. Anyone open quickly. We are little short of time.
Pneumococcal vaccine.
Pneumococcal.
Sorry.
Pneumococcal. Absolutely. Second is the meningococcal.
Meningococcal.
And third is
And
HIB.
influenza.
HIB. HIB. Hemophilus influenza type B. Right? So you must mug up this. This is Rattofai. You don't need to understand. You just need to remember 3 names. Right? That's it. So this again ask in the exam very frequently. Which vaccine give, which not to give. So you must know which needs to be given, which need not to be given. Fair enough. So let's jump to the next question. So this all things. Excellent question. Which of the following Hodgkin's lymphoma histology has the best prognosis? Is it nodular sclerosis? It's a mixed cellularity. It's a lymphocyte predominance, or it's lymphocyte depleted. Very, I guess, lollipop question. Good, Sania. You had given good answer. Pneumo, meningo, and influenza. Excellent job. Yes, Ashish Kumar Jala is also given good answer. Everybody has given the good answer, I guess. Yes. Tell me, this is the patient with you, and they are asking which has the best prognosis. Dr. Amal, if you want to speak little bit, I would be happy. Dr. Amal Amara Sinha.
Yes, sir.
You are Dr. Amal, right?
Yes, yes.
Sorry, I can't see this place. No problem. Tell me, sir. So what do you think? Why you selected mixed cellularity? You know, or it's a guess, just for knowledge?
I can't remember the exact. It's not a like I remember like it's mixed cellularity. But I don't know the definite definition or answer. So it's probably like a guess.
Okay, fair enough. No problem. No problem. No problem. Let's see what other experts are saying. We are around 50 people, 50 respected doctors are in and I'm getting only 10 questions, non-answer means 40% are not, 40 doctors, 80% audience is not giving any answer. Still I wait. 10 seconds I'll wait. Right or wrong, don't worry about anything. Post answer. If you don't post, then you'll confuse in exam. Anything you post, at least select A, B, C, D. Right, so let me go to the basic now again. This is a huge topic, very huge topic, lymphoma, and one of the most favorite topic. Anyway, we will discuss on lymphoma separately. So let me quickly tell you the things, right? Lymphoma, there are two main subcategory, Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma, presence of RS or Reed-Sternberg cell is present. Here, Reed-Sternberg cell is absent. This is the first and foremost, the basic and number one and biggest difference between Hodgkin's. So when you do any biopsy, lymph node biopsy, bone marrow biopsy, spleen biopsy, or any biopsy, if you find in biopsy Reed-Sternberg cell, it is Hodgkin's. If not, NHL, non-Hodgkin's. Hodgkin's and non-Hodgkin's, diabetic, non-diabetic, hypertensive, non-hypertensive. So N for non, right? So non-Hodgkin's lymphoma. Hodgkin's lymphoma is Reed-Sternberg cell. Here, no Reed-Sternberg cell. Biggest difference. Rest of the things are similar. Everything will present in same way. Fever, weight loss, night sweat, lymphadenopathy, hepatosplenomegaly, bone pain, weight loss, marrow infiltration, long list. I can tell you, right? What differentiate is a histology, right? Number one. What is Reed-Sternberg cell? So this is a cell. And in the cell, this is lymph node. I can say lymph node. I did a excisional lymph node biopsy. I did, and I see under the microscope this all eye appearance. This is all eye. Can you recognize this is like a little all? Yes or no? My picture is not good, probably not a good drawing person, but just try to make you understand. So this is all eye, right? So this is identical cells, right? Looks like identical, all eye, right? And this is called as a Reed-Sternberg cell. And this all eyes is looks like this exactly in this picture, right? Let me tell you, right? So this is, you can see this is all eye. Can you recognize it or not? Yes. Yes or no? My cursor. Yes or no?
Yes, sir. Yes, sir.
So this is all eye. This is all eye. This is all eye. This is all eye. Right. So this is a classical of Reed-Sternberg cell. So sometimes they may give you the picture of this and try to tell you, oh, identify this. What is Hodgkin's, non-Hodgkin's, AML, ALL? Answer is Hodgkin's. Here you can see arrow all eye. Can you see two identical cell? Right. You get it? So this is the classical Hodgkin's lymphoma, right? So what we were discussing is histology. So first you have to make a diagnosis of Hodgkin's lymphoma. How you diagnose the Hodgkin's lymphoma? Excisional biopsy, exam question. If you have four option, excisional biopsy, incisional biopsy, true cut biopsy, fine needle aspiration cytology. What is the best? Best is excisional biopsy. So this is answer. Number one question. Number two question. Subtype, histology, histopathology, right? So here the histopathology. Mute, brother, mute. So histopathology, there are four histopathology. Nodular sclerosis, most commonest. Write down. I will share the slide. Most commonest. If they ask again, like AML, I told you, initial investigation, CBC peripheral smear, diagnostic in first light bone marrow, confirmatory test, flow cytometry, prognostic test, cytogenetic. Four answer in a one question, same here, four answer in one question. Right? Nodular sclerosis, most common. Second most common is a mixed cellularity. Best prognosis when lymphocytes are too much, means lymphocyte predominance, best prognosis. Best prognosis means they respond quite well to the treatment. What is the treatment? ABVD, adriamycin, bleomycin, vinblastine, DTIC. It's the drug of choice, and this is the worst prognosis. Worst is the bad. Worst is the bad. So which has the bad prognosis is the lymphocyte depleted. So for histology different answer.
زون گو گوی ریاست سگ ریاسیه بدی میگن چی
So nodular. Can you please make your mic mute, brother? Brother, make your mic mute. Can you tell brother who is this? Very disturbing. Okay, so you got the idea, right? So what is the most common and second most common, right? So most common and who is this man? Can anyone tell, please? Come on, I mean, this is what very frustrating. They can't understand. Please make your mic mute, brother. Why you are disturbing? If you are not interested, please leave the class. I'm doing so much of hard and sincere work and you are not understanding the importance of this. I'm here for nothing. Okay, so sorry. So which of the following Hodgkin's lymphoma is the best prognosis? So everybody understood well, right? Yes or no? Everybody understood well? So
Yes, sir.
yeah, so there is a 4, right? If they ask you the most common, then nodular sclerosis, second most common, mixed cellularity. Best prognosis means what? Prognosis, what do you mean by prognosis? When anybody diagnosed with some disease, XYZ, say for diabetes mellitus, how is the prognosis is one? How they live 2 years, 5 years, 10 years down the line, how they respond to the treatment. It is called prognosis. So if you have a histology of lymphocyte predominance, it's a best prognosis means they respond quite well to the treatment, they live longer. This is prognosis, that's it. Bad prognosis means even if you give a treatment, they have not good prognosis, they probably not live longer time, and that is why histology is extremely important in any histology, any malignancy, right? Squamous cell carcinoma, adenocarcinoma, right? We are seeing, right? So why we are knowing the histology? Because histology decide the prognosis, and prognosis is only and only is decided by the histology, right? So here the answer is a uh, lymphocyte predominant. They are asking the best. If they change the answer, worse prognosis, then answer may change to depleted. That's it. So this is what the thing is. This is Steinbach's red Sternberg cell. I told you not going much in detail. I'll share the PowerPoint, right? So with you very quickly, they may sometimes ask you the drug adverse effect. So in Hodgkin's lymphoma, the treatment of choice is ABVD. I don't know whether you knows or not. And non-Hodgkin's lymphoma, the treatment is CHOP, CHOP. Adriamycin, adriamycin is cardiotoxic drug. So 2D echo is very, very important baseline before starting the adriamycin. So, right. So doxorubicin, cardiomyopathy, you must do the 2D echo before that, right? Bleomycin is a pulmonary toxicity, cardiac and then pulmonary, and bleomycin, pulmonary fibrosis can occur. So you need to do baseline pulmonary function test for this patient. We are doing every day in our OPD and practice. V stands for vinblastine, right? It can cause peripheral neuropathy, and dacarbazine again cause pulmonary fibrosis. So these are the common most important side effects. They may sometimes ask you in exam, which is given in the slide. I'll share later on. And doxorubicin, cyclophosphamide, vincristine, and prednisone. So by and large, the same drug, little change in drug, but right, because cyclophosphamide is not here, cyclophosphamide is here, right? And steroid is not here. P stands for prednisone, steroid is here. So this is little change, but these are the important drug adverse side effect. Next question. A 23-year-old woman comes to the emergency department, increased menstrual bleeding, gum bleeding, right? When the and she brushes her teeth and patchy on the physical examination. Physical examination is otherwise normal. Her blood workup shows HB12, WBC 7,000, platelets 17,000 per cubic millimeter. Her renal function, liver functions, viral serology. What do you mean by viral serology? Means HIV, HBsAg, and HCV. It is negative. ANA, anti-nuclear antibody, normal. What is the appropriate next step in the therapy? Are you going to do the bone marrow for this patient? Are you going to give the intravenous immunoglobulin to the patient? Are you going to give the steroid to this patient? Are you going to do and check the antiplatelet antibodies in serum or plasma? or you start the platelet transfusion. So just little simple question. Don't get confused. Think over it 10-15 seconds. Get back to me. Yes, Saima. If you want to speak, Saima Salim Malik. If you want to little discuss with me, you can speak up. You selected the answer intravenous immunoglobulin, so I want to understand. Are you there? Am I audible to you, Dr. Saima? Yes, Dr. Tariq. Would you like to tell something why you want to do the bone marrow for this patient?
Because, sir, we have to come to the conclusion for the diagnosis, actual diagnosis.
Actual diagnosis. Okay. So what do you think? If you don't do the bone marrow, what do you think? Say, for example, if you are not doing the bone marrow for this patient, or patient is refusing for the bone marrow, let's understand, just discussion purpose. Then what is the first diagnosis in your mind? Or where is the problem? Where is the problem first? Huh?
Problem with the platelets.
Excellent. So first find out, that is also important, where is the problem. So problem is in the platelet. So platelet is a problem, right? Thrombocytopenia, low platelet count, right? Okay, fine. Now you think in which condition the platelet counts can be low? What are the common cause? What you see in your practice in general? I mean, forget about this scenario.
So in this case, there is some leukemia blood disorders. In this way, it is found.
Okay, so you are thinking of leukemia, right?
Yes, and
Okay.
also is a female patient is a menstruation, menorrhagia or menstruation bleeding. It also leads to lose the platelet counts.
Fine. Now just to clarify your thought process.
Disorders, it might.
Right. So let's take leukemia. You told me leukemia. You want to rule out leukemia. That is why you want to do the bone marrow, right? If I'm not wrong.
Yes.
Right. So now you tell me yes or no. Answer is only yes or no. In leukemia, do you feel any more than 20% of blast cell in blood or bone marrow? At least in the blood, 20% blast?
No, sir.
No. Do you feel any there is a hepatomegaly, splenomegaly or organomegaly?
No, sir.
In leukemia, WBC is usually increased or decreased. Do you see any increase or decrease in WBC count?
No, normal.
Because of leukemia, you may have some time, right? Anemia usually presentation. Do you feel any anemia is there in this patient?
Nothing.
So by and large, you see nothing favors again leukemia, right? No blast, no organomegaly, no WBC problem, no HB problem. So hemoglobin at only 17,000 platelet, right? Isolated. We call it as isolated, right? When hemoglobin, WBC and platelet, say for example. So hemoglobin normal, WBC normal, only platelet low. The term is called as isolated. Isolated means single, akela, only one thing is low. Isolated, right? In our group, we remove somebody, one person, isolate them. Isolate is alone now. So only single person is low. So only platelet is low. So it's an isolated thrombocytopenia. And in otherwise normal, isolated thrombocytopenia. There is a long list, nah? Right? You may think of some dengue infection. You may in India think of malaria infection. It could be sometimes drug induced. It could be heparin induced. It could be DIC, right? It could be ITP. It could be leukemia. I have long list. It could be HIV. HIV present with also thrombocytopenia. There are long list of low platelet differential, isn't it? But now go back to the scenario. 23 years old woman who is menstruating heavily. So platelet count. I told you first one Willebrand lecture little few slide back. Platelet bleeding is which bleeding? Menstrual bleeding, gum bleeding, petechial bleeding. So it looks like platelet bleeding, and which is confirmed by the low platelet, right? With normal hemoglobin and normal everything. So here you can think of first condition here is called as the ITP. immune thrombocytopenia. Why it is not dengue? Because there is no fever, no joint pain, nothing. WBC is also normal, so you are not thinking of dengue. Why not malaria? Because there is nothing malaria in peripheral smear. Why it is not drug? Because there is no history of drug in this scenario. Why it is not heparin? Because patient is not administered any heparin, so it is gone. Why it is not DIC? Because in DIC what happens? DIC what happens?
There is no that
Right?
design any patient.
So platelet count is low, plus PT is high, APTT is high, fibrinogen is low, and there must be history of fever, infection, septicemia. Then they go in DIC, right? There is nothing, right? So DIC is not there. Leukemia I already told there. So isolated thrombocytopenia in otherwise normal individual, until proved otherwise, it is ITP. That is called immune thrombocytopenic purpura. The recent name is, right, immune. Earlier name was idiopathic. You get two terms in book: idiopathic thrombocytopenic purpura, or and now the science knows that there is some kind of auto antibody or immunity related problem, so it is called as the immune thrombocytopenic purpura. And what immune? There is a platelet in the blood, right? There is a platelet in the blood. So this platelet is attacked by anti-platelet antibody. It destroy the platelet. So this is immune mechanism, and that is why they thought that some kind of antibody kills the platelet. That is why immune thrombocytopenic purpura. And when the case is classical, let me tell you, this is again a big exam trick. This case is a classical of ITP. No need to do bone marrow, believe me, right? Even after doing the bone marrow, you have to treat this patient, right? So no need to do bone marrow biopsy. Nobody does the anti-platelet antibody in plasma practically. Even if you do my test, there must be some antiplatelet antibody. You understand? That does not mean I have ITP. Is that clear? Platelet transfusion is not required in the patient who is not excessively, massively bleeding or in shock. Now you have two options: confusion, prednisolone or immunoglobulin. Somebody answered me immunoglobulin. Write only two indication for immunoglobulin in ITP patient. Right? Remember 2B shortly. B1 is brain bleeding, another is a bowel bleeding, and these two are massive. So in history they mention massive GI bleed or intracranial hemorrhage. What is the best drug of choice? Prednisolone. Intravenous immunoglobulin. That's it. This is bottom line. No need to mug up. No need to rectify. Otherwise, there is no brain bleeding here, no bowel bleeding here. So this is also gone. First line treatment in ITP is a steroid, because it's a antibody or autoantibody or autoimmune disease. Any autoimmune disease, if you don't know anything, first line is steroid. Any autoimmune disease in body, if you don't understand anything, give steroid. It's answer. Rheumatoid arthritis, steroid, right? Then SLE, steroid. Ulcerative colitis, Crohn's disease, autoimmune, steroid. This vasculitis, steroid. Blah blah, steroid. Is that clear? So this is also autoimmune. Give the steroid. So steroid is a first line treatment for any autoimmune disease, including ITP, right? So steroid is a first and foremost drug here. If steroid does not respond, then you can go for different treatment. I will teach you whole ITP later on, but this is the basic I'm telling you now, right? So this is the ITP, right? So right, prednisolone, bleeding in case mild, meaning there is no intracranial or massive or major GI bleed, right? So this IVIG is not required. Prednisolone or steroid is the best first line initial treatment, and ITP is a diagnosis of exclusion, as I told you. Nothing is there. This is ITP. That's it. This is guideline, treatment guideline, presentation. No bleeding, no bleeding. Only just platelet count is low, right? So every time it's not mandatory. I have seen hundreds of patients and reference in my city in Ahmedabad that I got a call from ICU that platelet count is 20,000, but patient is fine. He is moving around in, right? There is no bleeding. So we don't need to treat the patient. No treatment. You just monitor, na? Don't get panic, right? And dengue, there are thousands of patients, hundreds and thousands of patients in India, in every part of India, in season, right? So dengue, everybody has a 20,000 platelets. So you can't treat everybody with platelet. Platelet 20,000, don't get panic. They are not bleeding, wait and watch. This is general guideline, right? Mild bleeding, like this patient. What patient? Petechial, menstrual bleeding. Give glucocorticoid. Glucocorticoid is a steroid or prednisolone is a first line treatment. I told you GI, brain and bowel, right? Give immunoglobulin or NTD is another injection, NTD, right? That's it. So this is how we treat. So you should just not keep the numbers in mind. Site of the bleeding is important. Number of the patient, platelet count is important. Also, patient's clinical condition, even in aplastic anemia. Aplastic, have you heard of aplastic, right? So aplastic anemia, we have a platelet count. Aplastic anemia, we have many patients of aplastic anemia, right? I have a patient, many patients, my patient, 5,000 platelet, no bleeding. Believe me, literally I'm following for 6 months, 12 months, 1 year. They are not bleeding, they are coming every monthly in follow. You understand? What is the worst low platelet count? Is the leukemia. If you have leukemia, so see here 5,000 aplastic anemia, I am not giving any transfusion, no platelet transfusion. I am not giving platelet transfusion. And leukemia 10,000 platelet, I am giving the transfusion, even though there is no bleeding, because leukemia is a platelet number as well as platelet functions disorder. So they bleed more. This feel you will get after doing some good amount of year of clinical practice. So I've seen many patients, those who are with leukemia, it is written in the book as well. So the platelet transfusion threshold may change from disease to disease. Got it? So dengue 10,000, I will not transfuse. Aplastic 10,000, I will not transfuse. Acute leukemia, myeloid leukemia 15,000, I will transfuse. You got it? So number is not important, along with what underlying condition you treat for the patient. That is also equally important, right? So don't always keep a watch on the number, but also keep in the underlying conditions as well, right? So this is the general guideline. I will share the PowerPoint. Don't worry. Just remember this basic funda. Is that clear to everyone? Yes or no?
Yes, sir. Yes, sir. Very good.
Yes, sir. Yes.
Wonderful. You all are brilliant audience. Yes. What is the next question? What is the single most accurate test for myeloma? This is hematology we are going. What is the single most accurate test for myeloma? Is it skull X-ray? Is it bone marrow biopsy? Is it 24 hours urine test or 24 hours urinary protein, what we call serum protein electrophoresis, urine immunofixation electrophoresis? Dr. Abrar, would you like to comment something? I would be glad to have you on board. Probably easy questions. Yes, Dr. Monica Gupta, any comment?
Benz-Jones proteins are characteristic of multiple myeloma, sir.
Benz-Jones protein. So what is Benz-Jones protein?
Sir, these are immunoglobulin light chains which can be detected in urine electrophoresis.
Okay, so say for example, if you do the urine electrophoresis and Benz-Jones protein is not found, that means that there is no myeloma?
No, so there's still some other bone marrow biopsy and serum electrophoresis to be test to be confirmed.
No,
Skull
no.
X-ray.
Let's discuss again this question. You and me only. Consider you and me in the class only. Don't worry about 48 people. Again, read the question. What is the single most accurate test for the myeloma? Means doing this test, 100% confirm this is myeloma, this is not myeloma. So do you think urine electrophoresis, if negative, then you say, oh, patient, you tell the patient, counsel the patient, okay, don't worry, your urine electrophoresis, IF is normal, you go home, there is no myeloma. Would you counsel in that way?
No, sir. The answer can be skull X-ray also, because skull X-ray are also characteristic in multiple myeloma.
Again discuss. If the skull X-ray is not showing specific lesion, is called as a osteolytic punched out lesion. Have you heard of this word?
Yes, sir. Yes, sir.
Osteolytic punched out lesion.
Punched
Right?
out.
Right.
Yes.
So if you do the X-ray of skull and X-ray
Yes.
of skull does not show punched out lesion, then you tell patient, okay, you go home, there is no myeloma.
No, sir.
Then what will you do?
So I think serum protein electrophoresis can also with a
Fine.
probability.
So serum protein electrophoresis also shows no protein or no M band, no monoclonal band, no myeloma band. Then you tell the patient that okay, there is no myeloma, you go home.
So then the bone marrow biopsy is a sure. It's the most
So
accurate.
that is the answer, my sister.
Yes, sir.
That is the answer. If
Yes.
bone marrow, right? Now this is the learning, right? You understand, you never forget now, right? So bone marrow, what happened? This is bone marrow.
Yes.
See my bone marrow video on YouTube as well. There are thousands of followers.
Yes.
So bone marrow biopsy, I did more than 3,000 so far. So bone marrow, what you see, there is a cell called as a plasma cell. This
Yes.
is a plasma cell. If
Yes.
you want to know the quantity, 5%, I mean 2 to 3%, max 5%, normal plasma cell. Got it?
Yes.
In bone
Yes.
marrow. This is bone marrow. I'm giving you the picture. So I did a bone marrow from posterior superior iliac spine. How to do it? Go and check my video on YouTube. So bone marrow biopsy, you did it. You see 5% plasma cell normal. Anything more than 10% of abnormal looking plasma cell is multiple myeloma.
Okay.
If skull X-ray is normal, if urine is normal, this is not showing any M band, this is normal, everything is normal. But if the bone marrow shows 10% plus plasma cell, it is none other than multiple myeloma.
Okay. Yes, sir.
Is that clear to you?
Yes, sir. Yes.
Any
Got
doubt?
it. Yes. No, sir.
Right? Now tell you the logic again. Right? There is a one formula called as a CRAB. Have you heard, Dr. CRAB? There is a two criteria of diagnosis multiple myeloma. Right? Myeloma is also my very favorite topic. We did more than hundreds of transplant for multiple myeloma. Anyway, so this is a major criteria and minor criteria to diagnose this thing. Major is bone marrow. If you see more than 10% of plasma cell in bone marrow, it is done. It is myeloma. Or another is if you do the tissue biopsy and you see the plasma cytoma, it's a major criteria. Is that clear? And minor criteria we called as a CRAB.
Yes.
Many people have heard CRAB. C stands for calcium, R stands for renal, A stands for anemia, and B stands for bone. Skull X-ray is one of them, bone. Got it? These things can see only in 25% of the patient, doctor, not in all 100% patient. Got it? Monica, you got it? Right. So this 25% patient can see this. Either they have high calcium, either they have a renal failure, they have a bad anemia because of bone marrow infiltration, and they present with a fracture. Right? But not all the patient present with hypercalcemia, CRF, I mean creatinine present with a 3 milligram per DL, or they present with fracture. Not all the patient. So if you are lucky, you get a skull X-ray changes. Got it, Monica?
Yes, sir.
Right? But 75% or 70% patient may not have any bone changes. So your skull X-ray is normal. They are not secreting the protein in the urine. Urine is normal. They are not showing high amount of this bad protein or monoclonal protein in plasma. So serum protein is normal. Urine protein is normal. Only
Yes.
thing categorizes the bone marrow biopsy. So don't forget it. Got it?
Yes.
So
Yes.
I had given you the quick review, but we'll discuss myeloma in detail later on if you are interested.
Thank
Contact
you.
me. Fine. So this is what the thing is. So 10% plasma cells, 10% I told you, right? So 10%, anything more than 10% plasma cell is a multiple myeloma. Going quickly, let me cover a little more. Okay, this is important question. Let me think. Again, we'll discuss. 16 years boy presented to GP complaining of nosebleed and bleeding after brushing tooth. So kind of platelet bleeding. Keep in mind platelet bleeding, nosebleed, gum bleed, menstrual bleed, patchy, not in joint, not in cavity. It is factor bleeding. This is platelet bleeding. Nobody will give you in the exam, but I'm just to make you sure. I'm giving you clue. He is unsure of how long this has been occurring, but decided to seek advice after having a continue excuses himself from the lessons. On examination, you notice that he has some skin bruise. A blood test show a prolonged prothrombin time, bleeding time, sorry, activated partial thromboplastin time, platelet counts and prothrombin times are all normal. The most likely diagnosis is, now again use your brain, do some brainstorm. What's the abnormal? In any question, first try to find out what is abnormal. Mindila, I will tell you what is the difference between smoldering and that. Just keep a question in mind. Once we finish, they will do it. Everybody is a brilliant now after my lecture. Great, I'm happy. Looks like I'm a good teacher. Anyway, so this is all A. Nobody has given the B, C, D or E anything. So I can't catch any person that, oh, why you have selected B, right? Wonderful. You all brilliant. Can anyone open, volunteer this time? No name. Why one Willebrand? What points in favor of one Willebrand? Just for discussion purpose. Anyone volunteer?
Sir, because we already discussed it in von Willebrand disease. There is a deficiency. There is a functional because it binds the factor VIII.
Yes,
And
that's correct.
Secondly, it is also required for the adequate platelet function.
True.
So when it is deficient, it will affect both the platelet function as well as the factor VIII function.
Exactly. So platelet function affected. That is why bleeding time is high, right? And also it carries the factor VIII. So APTT is also high, right? Here platelet counts is normal. Prothrombin is normal because it is not affecting. Factor VIII is what? Factor VIII is not affecting the. It is affecting the internal pathway. You know internal pathway. Would you like to learn internal and external very quickly? Yes or no?
Sure. Yes, sir.
Everybody?
Yes, sir.
Yes, sir.
Please.
Wonderful.
Yes, sir.
Okay.
Yes, sir, definitely.
So I'm trying to see how is the energy level like me or not. Great. This is one of the best chart in your lifetime. I will guarantee you, you never ever forget this chart in your life. It is so confusing, but I'll take it very clear cut. This is called as a extrinsic pathway. This is called as an intrinsic. This is how it's given in the book. Pathway. This is common pathway. Is that clear? Yes or no?
Yes, sir. Yes, sir.
In extrinsic pathway, only one factor, that is factor 7. Now, where are all the factors gone? So, after 7, here is 8. Above 8 is a 9. Above 9 is 11. You thought, where is a 12? I'll tell you. Where is a 10? Here, 12. So, 7, 8, 9, 11, 12. Where is 10 gone? So, 10 is here. 2 multiplied by 5 is 10. This is how I remember. So 2 and 5 is also here. That's it. This is pathway. External pathway monitored by PT called as a prothrombin time. This internal pathway monitored by the PTT, partial thromboplastin time. Right? So anything wrong in factor 8, 9, 11 or 12, PTT will increase. Anything wrong in extrinsic pathway, PT will increase. Simple logic. Anything wrong in both the pathway, extrinsic plus intrinsic, then both will increase. PTT will increase, PT will increase. Got it? Anything wrong in 2, 5, 10, both will increase because it's merged, and this will cause final cascade, prothrombin to thrombin, and this thrombin will activate fibrinogen to fibrin clot, and this is called as a factor 13, as we discussed in the first MCQ or second. Right? Newborn presented with excessive bleeding umbilical stump. right? This factor, if deficient, it will not allow the blood clot to stabilize, and it is also called as a clot stabilizing factor. So this factor, if deficient, it will not stabilize the clot, and there is a excessive bleeding. So far it's clear, yes or no?
Yes.
If
Yes, sir.
if
Yes, sir.
if factor 8 deficiency, we called as a hemophilia A. You now remember the physiology days. If factor 9 deficiency, hemophilia B, right? So hemophilia A and hemophilia B, it is more common. 90 to 95% of hemophilia are A, hardly 2 to 5% are hemophilia B, and rest of the all bleeding disorder or clotting disorders are rest of the things. So now there is nothing simple, right? So just keep this chart in mind. Now look at the von Willebrand disease. So von Willebrand disease, what happened? There is something problem in von Willebrand factor, and there is problem in the factor 8. So where is the factor 8? Intrinsic pathway or extrinsic pathway?
Intrinsic.
Intrinsic.
Intrinsic pathway, when problem, what will increase? PT increase or PTT increase?
PTT.
So PTT, that is what PTT. So that is what in the scenario. Now you go back to the scenario. What increase? PTT increase. Now it is written here. Now PTT. Got it?
Yes, sir.
And platelets are not functioning well. That is why they are bleeding. That's it. So basically, von Willebrand disease, if you go bit in detail, it's a two problem. Von Willebrand factor which helps to clot the blood, and there is a two main three category in von Willebrand disease that we will see. Category 1, category 2, and category 3, or type 1, type 2, type 3. Three type of von Willebrand disease. Not much in detail, but for your understanding. So this is simple, right? There is a platelet problem, so bleeding time is high, and APTT is high. Why? Because this carry the factor 8, right? So it won't carry the factor 8. Factor 8 get disturbed, PTT will increase. That's it. This is what the chart is. So whatever they ask, keep this mind. I keep this chart in my mind. Any reference comes in the exam or in my hospital, I'll keep my head cool and calm, being a hematologist. Okay, what is problem? Platelet problem, PT problem, PTT problem. Both increase. Let me tell you, both increase. PT increase and PTT. Can anyone tell me which condition in both will increase? Can anyone tell me? Both increase. Very
DIC.
common. DIC. Excellent. DIC. Why DIC? Because DIC, when there is a clot forms, clot involve factor 8, factor 9, factor 7, everything involved, na? Intrinsic, extrinsic, both involved. So DIC, very common. And also platelets are also low in DIC. Got it? Because DIC is such a condition in which what is the consumption? Platelet consumption are there, factor consumption are there, von Willebrand factors are there. So when platelets consumption, platelet low, when factor consumption, PTT high. Simple. So this is what the classical scene in DIC. Low platelet, high PT, high PTT, low fibrinogen. That's it. So when I go to the ICU, I just look at the number. Even if I don't see the patient, I can tell ICU registrar. Okay, this is DIC. You go and give the platelet, you go and give the FFP, you go and give the cryoprecipitate. That's all. 90% job is done. Why? My fundas are clear. I know what I need to know, or I know what I need to do. That's it. So no need to mug up this pathway. This is the simple pathway. Is that clear? Now again you see warfarin. Why warfarin is warfarin increase the PT? Because warfarin acts on factor 7. Heparin. Why heparin PTT increase? Because heparin act on factor 10A. Factor 10A activity, anti 10A activity, right? So usually PTT increase, also PT is also increase. So just you need to remember what drug acts on which level, that increase. That's it. That's it. Nothing to remember, right? Nothing to mug up. Is that clear? Yes or no? Yes or no?
Yes, sir.
Yes, sir.
Excellent. Probably I made your job little easy, hopefully. Got it? So go and read it again. We'll discuss. I try my level best to give you the simplified idea of intrinsic, extrinsic, which we are always confused and we don't know where is the factor. 2 is where, 10 is where, 1 is where, 2 is where. So I try to explain you in a simpler 7, 8, 9, 11, 12, 2, 5 and 10. That's it.
Sir, what about liver diseases?
Liver disease is also, let me tell you, liver disease as well, right? So liver disease is what, right? I want to make you understand, not mug up only things. So this is a liver. This is a liver. Liver is a factory for all factors, right? Factor 7, factor 8, 9, all factors are forming in liver. So liver disease, you get also increase in PT and APTT. PT and APT. Why? Because factor 7 is also there, factor 8 is also there, factor 9 is also there, form in factor 12, all factor form in liver. So they are for affecting extrinsic, intrinsic. Increase PT, increase APTT. You got it?
Yes.
Yes or no?
Yes, sir. Yes, sir.
So write down the four reasons which increase the PT and APTT. Number one, both increase. Both increase. Exam question, even clinical questions. When you get a reference, PT and APTT increase. Both increase in where? No need to mug up. DIC. Why DIC? Because it involve all factors. Liver disease. Why all liver disease? Because factor 7, 8, 9, 10, all whole cascade form in liver. So liver disease. DIC. Third thing is a vitamin K deficiency. Why? Vitamin 2, 7, 9, 10. These four factors, right? These four factors is dependent on vitamin K. So when vitamin K deficiency, these four get disturbed. When 10, right? When 10 gets disturbed, common pathway. When 7 get disturbed, extrinsic pathway. When 9 factor disturbed, intrinsic. So intrinsic, extrinsic, common. PT, APTT both increase. Simple. Is that clear? Yes or no?
Yes, sir.
Yes,
Right?
sir.
So
Yes,
these
sir.
are the three reasons: vitamin K deficiency, liver disease, and DIC, where you get increase in PT and APTT. Just keep in mind. Oh, sorry. So jumping to the next question, probably you guys are also hungry. We are not able to finish oncology, so we may take little later in next session. But let me finish one or two questions. Is it okay with you if I take one or two questions more?
Yes,
Yes,
sir.
sir.
Yes, sir.
That means my lecture is enjoyable, hopefully. So this is von Willebrand disease. As I told you, von Willebrand disease three type, right? I told you three type von Willebrand disease. So what are the three type? Type 1, type 2, type 3. It is extremely rare, so forget about it now. 185% case 1 and 15% is this, and this is very, 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 very rare, right? So forget about it. Not much seen in clinical practice. So most common here the two different problem, right? Here is what problem? Quantity problem. Quantity problem means if the von Willebrand factor level is 200 to 400, here the level is only just 50. Means quantity is low. So quantitative problem. Quantitative. Here quantity is normal, abnormal quality. Here the level of von Willebrand is 300. Normal. Like platelet number disorder and platelet function disorder. Same way. Right. So here the number is okay, but the functions is not normal. And this is more dangerous. This is more dangerous. But fortunately in clinical practice, this is 85%. That's it. So this is type 1 and type 2. So this is a exam questions. This is a qualitative problem. One is a quantitative problem. Type 1 is a autosomal dominant and this is autosomal dominant. Both are autosomal dominant disorder, right? And what's the treatment? What's the treatment? Most important, very frequently asked the question. So there are 3 steps in treatment. You don't need to mug up, right? First is what? First is first line treatment. Desmopressin. Another name is a DDAVP. What is the factor? This is endothelium. From the endothelium, when you give the desmopressin, it goes to the endothelium and it is release more von Willebrand factor in the blood. So this is first line treatment. Simple. What is the action? This will release the subendothelial store of von Willebrand factor and it will stop the bleeding. So this is one treatment. Initial treatment. What if it is fails? You are given this desmopressin. No effect. No effect. What will you do? The second option is factor 8 replacement. because 8 is also there na, with 1 Willebrand, right? And factor 8 replacement replaces both 1 Willebrand factor and factor 8 both, because factor 8 has both the content. If it is fail, second step fails, and third is a, if both the not effective, DDAVP desmopressin not effective, factor 8 not effective, then there is a one ready to use available in the market called as a recombinant, means developed in the laboratory recombinant 1 Willebrand factor, directly infused to the patient like a blood transfusion. It increases the level of 1 Willebrand factor and stop the bleeding. Like platelet count is 10,000, patient is bleeding, you give 4 or 6 PRC or platelet rich concentration, bleeding stop. Same way, that's it. So these three treatment they ask, right? How you treat, what you treat, blah blah blah, right? So this is what the thing is. So this is about the von Willebrand factor or von Willebrand disease, right? The basic understanding. So after my lecture, you go and read it once again. Query will be solved again one-to-one as well. Drop me the message. Again, extremely important and last couple of questions. So bear with me for more 10 minutes. A 44-year-old Asian female present with a 2 months history of shortness of breath and lethargy. She denies any intolerance to cold or any changes in her weight. On examination, appears slightly pale. She states that she recently become a vegetarian. A blood film shows a presence of elliptocyte and blood result shows the following. So unfortunately, there is no report, so I'll skip these questions. Sorry. Unfortunately, I forget to upload the number slide, so you won't enjoy the slide. Next question. A 47-year-old woman present to clinic concerned about her recent ill health. She has noticed over the last 3 months that she has been suffering from headache, fatigue, recurrent infection. She notes that she has rarely been to a doctor before and otherwise lead a healthy lifestyle. She decided to see a doctor when she noticed petechial rashes on her arms and legs and limbs. On examination, there is a no organomegaly. Blood test reveals MCV of 105, pancytopenia. Bone marrow shows hypocellular bone marrow on bone marrow biopsy. What could be the diagnosis? Chronic myeloid leukemia, myeloproliferative disease, aplastic anemia, iron deficiency anemia, acute lymphoblastic leukemia. Interesting. Apply your knowledge. I already told you a lot of things in last few slides. Try to solve one by one. Don't be in hurry. Take 10-15 seconds and try to answer. We are around 50 people in the class and there are only 5 answers. Right or wrong, post everyone. Dr. Manan, can you tell me something? Manan is there in the class or not? We are about to finish, don't worry. I know you are hungry. Manan, would you like to tell something? Any volunteer? Any volunteer? One. Explain this. This is last couple of questions. We are done. Any volunteer? Okay, your mic is not working. It's fine, no problem. Dr. Nasib. Dr. Nasib Muhammad. Would you like to comment?
So due to pancytopenia, sir, aplastic anemia.
Okay, so let me tell you, learning purpose. Okay, so let me tell you the differential diagnosis. Pancytopenia means hemoglobin is 8, example. WBC is 2000 and platelet is 100,000. So this is pancytopenia, right? All three counts are low. What are the differential diagnoses? It could be acute leukemia, right? It could be MDS, myelodysplastic syndrome. Third, it could be aplastic anemia. Fourth, it could be PNH, paroxysmal nocturnal hemoglobinuria. Fifth could be B12 deficiency. We have seen already pancytopenia, high MCV. Now, how you differentiate this is aplastic anemia? On what ground you answered the aplastic anemia? Just understanding. Answer is correct. Don't get confused. Aplastic is the answer, but I want you to understand why it is aplastic anemia. So let me tell you, chronic myeloid leukemia. Why it is not chronic myeloid leukemia? Because in chronic myeloid leukemia, total count is increased neutrophil, right? And it is hypercellular bone marrow. Do you think these three things are present in this scenario, doctor?
No, sir.
So there is no high count, no neutrophilia, and they are saying hypocellular, not hypercellular. What they are saying? Bone marrow is hypocellular. So this is gone. Am I right or wrong?
Yes, sir.
Excellent. Another iron deficiency anemia. It is not the answer. Why? Because in iron deficiency anemia, only hemoglobin is low, WBC and platelet counts are normal. There is no pancytopenia. They are saying pancytopenia. Got it? They are saying pancytopenia. So why there is a WBC and platelet low in iron deficiency? When there is iron deficiency, it affects RBC, hemoglobin, only low HB. Is that clear? Yes or no?
Sir.
Yes, sir.
Excellent.
Yes, sir.
Acute lymphoblastic leukemia, not anemia. Acute lymphoblastic leukemia. Why not leukemia? Because there should be a more than 20% blast in the bone marrow or blood, which is not mentioned, means not there. Number two, acute lymphoblastic leukemia, there is a hypercellular marrow, hypercellular, and they are saying hypocellular marrow. So it is gone. Myeloproliferative disorder is what? The name is absolutely contradictory. Myeloproliferative. Myelo means bone marrow is a myelo, and proliferation means proliferate, means generation, means more high. So HB should be high, WBC should be high, platelet should be high, and they are saying pancytopenia. So myeloproliferative disease is also gone. So even if you differentiate, what L alone is remaining is aplastic anemia. This is one way of differentiate. Now I will show you 10 points in this scenario which 100% confirm, oh, this is clear cut case of aplastic anemia. So I ruled out all. I don't know. I'm not a hematologist. I'm a lay. I'm just medical graduate, recent. So this is how I can, if I know the things, I can differentiate one by. This is not that. This is another way of solving the MCQ. When you don't know the answer, rule out. Is CML looks like this? No, gone. If myeloproliferative looks like this? No, gone. What else? Like, have you seen the Amitabh Bachchan KBC? Right, 50-50. Remove all the options. This two, select one. Got it? So this is like that. Got it? Select it. Now the CML. Sorry, aplastic anemia. Right? Let me tell you. Aplastic anemia is disease of female, usually 20 to 40, max 50. Two criteria match, 20 to 50 match, female match. Clear? Listen more 10 criteria.
Yes, sir.
Concern about her recent health, right? She noticed that 3 months she has been suffering from headache, probably because of anemia, headache and fatigue, recurrent infections because of WBC. Is that clear? Right? When doctor noticed petechial rash, so pancytopenia confirmed, low HB fatigue, low WBC, recurrent infection, low platelet bleeding, all three there, right? No organomegaly. So organomegaly is not there. Again, question arises, sir, when there is a pancytopenia with organomegaly, again the answer is acute myeloid leukemia, acute lymphoid leukemia, where you usually see organomegaly. Not always, but you can see, especially ALL. right? So here no organomegaly. MCV is high in aplastic anemia. Pancytopenia is there, and absolutely hypocellular bone marrow. So you can see 1, 2, 3, 4, 5, all full of aplastic. If you don't read this, if you don't read this, you can make differential diagnosis, likely something with the hypocellular. And what is hypocellular? Aplastic. The name itself suggests aplastic. It is misnomer. It is not aplastic anemia. By me, its name is aplastic pancytopenia, because you have all the three cell lines are low, not just anemia. Got it? But for years and years in the book, it is aplastic anemia. So we are doing it as a aplastic anemia. But by me, its name is aplastic pancytopenia. Anyway, because all three cell lines are low. Anyway, and bone marrow is hypercellular. See, this is a normal bone marrow. I tried to posted a slide just to make you better understand normal bone marrow, and this is aplastic. What I'm showing is here all red, and this all blood cell, this all blood cell, this all blood cell, hematopoietic tissue, complete, right? It is normal hematopoietic tissue. What my cursor is going, all hematopoietic tissue. And here see, can you see kind of such hematopoietic tissue here? Nothing. This is all fat cell, fat globule, fat. So 90% of the bone marrow is replaced by the fat. What my cursor is showing is all fat cell. You can't see any hematopoietic tissue or hematopoietic cell. There is a defect in the generation, right? Production, and this production generation problem is where? At stem cell. So it's a stem cell disorder. Stem cell job is to make a red cell, its job is to make white blood cell, and its job is to make platelet count. This is a job of stem cell. It's a stem cell disorder, so it can't make anything. Bone marrow is khali kham, it's empty, and empty is called as a aplasia. A means absence, plasia means production. Absence of production is aplasia. So it's aplastic anemia, classical hypocellular marrow, right? So, and this is, and if I can tell you the third slide here, right? Third slide, same, like AML, ALL, or MDS, too much cell. Even this white cell is gone. Everywhere cell. It is hypercellular marrow. You got it? So this is hypercellular marrow. Once you see, I will share my bone marrow slides with you in next time. So you can see what is hypercellular marrow. Is that clear to everyone or no?
Yes, sir.
Clear, sir. Thank you.
Yes, clear.
Wonderful, brilliant, wonderful. Got it. So this is what the aplastic anemia. And last questions for today, followed by feedback. We will cover the oncology. I little exceed my limit because I don't want to go just fast and get you the answer. I want you to understand the logic of the answer. That is why it took little long, but probably it will helpful to you to develop your thought process. Oncology, I wish to finish, but it's a less time, and you guys are also hungry. So probably next Sunday or next of the next Sunday, I will manage, and we'll discuss again the separate oncology. This is what I did completely hematology. I did not mix up all blood related issues. Last questions for today. A 70-year-old woman complain of tiredness, fatigue, weight loss, blood revals, taste revals, elevated WBC. Examination splenomegaly is palpated, cytogenetic is positive, right? For Philadelphia chromosome, and the diagnosed she diagnosed as a CML. The most appropriate treatment of CML is what? Hydroxycarbamide or hydroxyurea, imatinib, venesection, stem cell transplant, or dasatinib. Yes, anyone, volunteer. Probably this is a lollipop questions for you guys. You all are very brilliant in hematology, I know. I'm looking for one wrong answer, but fortunately not a single wrong answer. Great, anyone volunteer. Dr. Khadija, any comment? Dr. Khadija.
Hello, sir.
Yes, sir. Good afternoon, madam.
Good afternoon, ma'am. Sir.
Yes, please. Tell me why you selected imatinib.
Imatinib is known to be the drug that you generally give with CML. As of now, for a 70-year-old woman, a stem cell transplant might be quite difficult.
True, absolutely true. Then why not hydroxyurea? Hydroxyurea also reduces the count. Imatinib is also reduces the count. Dasatinib is also reduces the count. Imatinib and dasatinib is the same group of drug that is called TKI, tyrosine kinase inhibitors. So why not dasatinib? Why imatinib?
I'm not too sure about that, sir.
No worries. It's a learning. Anyone wants to differentiate why imatinib, why not dasatinib? No one. Imatinib with lesser side effects. Excellent. True. Nadine Dia. That is also true. Side effects are less. Absolutely less. Agreed. So basically, last question. I'll take 2 more minutes if you don't mind. 2000. One drug came in the market. The name is imatinib. Means now 23 years in the market. Rather 24 started 2024. Right? Before that, chronic myeloid leukemia. There are three phases: chronic phase, accelerated phase, blast crisis. All questions in exam, different. So if somebody asks you three phases of CML, 95% of the patient has a chronic phase when they diagnose at the time of diagnosis. 5% is accelerated and less than 1% at the time of diagnosis is blast crisis. What happens in chronic phase? Before 2000, so somebody diagnosed in 1990s, CML, they die in 3 years. They die in 3 years. Chronic phase CML. No drug. After this 2000, the imatinib comes in the market. Instead of 3 years, they are living 10 years, 20 years, 25 years. 25 is yet to come, but I have seen many patients in my practice. I treated and diagnosed. They are living absolutely fine more than 10 years. So prognosis is absolutely changed. Nobody does world over now bone marrow transplant as a first line treatment for CML. Why? Because it's just the one single drug, one oral tablet, imatinib of 400 milligram, right? The brand international is very famous. It's called as a Gleevec. So this drug will completely change the pathophysiology of the lung. And this drug is the first drug invented by a company called as a Novartis. Little interesting story I'm telling you, 1 more minute. And the scientist is known as a Drucker, Brian Drucker. You go and read it. Don't just read the books. Try to enjoy the medicine. So Brian Drucker, this Brian Drucker, who was working with the Novartis, he invented one pill, and this called as the Gleevec, and that was in the United States reputed magazine Times. In the Times, there is a article on the front page, Magic Bullet of the Era. Magic Bullet of the Era. Go and read it. Google it. Right? Magic. And this drug will completely open up the doors in oncology. By my small experience of 20 years, people are practicing for 50 years. So whatever I gathered, it completely changed the pathophysiology of this disease, and it opened up the door for all the cancer in a targeted therapy. This is called as a targeted therapy. Why? Because it target one oncogene that is called as a BCR-ABL. What happens when the WBC, right? One WBC divide in 2 or 2 divide in 4. What is the problem here? There is a problem in the switch. I can tell as a switch, like electric switch. And this switch is a BCR-ABL. When there is a CML, this switch is out of order. There is no control on this. If you switch off, if you block this gene, this complete proliferation will stop, and that is called target. So you are targeting one gene, oncogene called as a BCR-ABL, which we can detect in the blood by giving the quantitation in terms of percentage, maximum 100% BCR-ABL. When they become normal, there is a 0% BCR-ABL. I have hundreds of patients who started with 100% BCR-able CML chronic phase. Now they are absolutely normal. I'll share the report, recent one I seen yesterday patient. Absolutely zero. So this drug is really a miracle. And this drug is a drug of choice. Dasatinib is also drug of choice. Another is a imatinib, dasatinib. Another drug is a nilotinib. If you know the third drug, nilotinib. Nilo. Fourth drug is a bosutinib. These all drugs are comes in the market in last few years, but this is a first line treatment. The biggest advantage is easier available, cheaper the cost, minimal side effect or toxicity, right? And long term safety profile and data are available, because first drug was invented was the imatinib. So those are on imatinib. Say for example, they have taken 2 years, 3 years. Now they become resistant. Then we go for the dasatinib. If they go for resistant, we go for the nilotinib. If they resistant, we go for the bosutinib, and they go resistant, we do bone marrow transplant. That's it, simple. But bone marrow transplant is almost gone, because just with the one pill, people are living years and years. So that changed the complete prognosis and pathophysiology of the world of CML. So this is a very nice and interesting story, right, of CML. So drug of choice is imatinib, and this is only the disease which can diagnosed on cytogenetic by having a presence of Philadelphia chromosome. Have you heard of Philadelphia or not? Yes or no? Have you heard of Philadelphia chromosome?
Yes, sir. Yes, sir.
Right. So this is Philadelphia chromosome. So Philadelphia chromosome, why the name? We just mug up. Why Philadelphia? What is Philadelphia? So Philadelphia is nothing. It's a city in United States, Philadelphia. It is invented in Philadelphia. It's by Philadelphia. That's it. There is nothing, something rocket science. Got it? So this is Philadelphia chromosome, right? So if you invent something in India, we can give it an Indian chromosome. That's it. So this is a picture of CML, peripheral smear. You go and read it. And this is the story of CML, right? So this is normal chromosome. We forget the chromosome, but I'll remind you, short arm, long arm, right? This is a pair, 9 and 22. This is normal. This is, it looks like. So what happened? One portion of BCR and one portion of ABL, right? They translocate. So one part of the short arm, one part of long arm. So short and long, it's gone from here, it's gone from here. That is what we call as a deletion. Have you heard of word deletion in chromosome? 13q deletion, trisomy, monosomy. Yes or no? Right? So deletion is something lost from the chromosome, that is called deletion. So deletion from 922, and it create a one new chromosome, and that chromosome is a Philadelphia chromosome, and the oncogene is BCR-ABL. So what exactly the imatinib is doing? It blocks this receptor, and which prevents the proliferation of white blood cell, and your CML is under control. Your WBC from 1 lakh, it will come to 4,000 once you start the imatinib in 3 months. That's it. It is called as a complete hematological response. We'll discuss later on. So that's it. So this is the drug, and this is the targeted drug. Thank you very much for your kind attention, and thank you very much for being with me for almost 2 hours and 25 minutes. Hopefully, I tried my level best to make this lectures absolutely enjoyable, interesting.
Thank you, sir. Like
Right.
it's
So now one minute, brother. So another news is that I am coming to Dubai on 28th of the January to 10th of the February, almost 2 weeks in Dubai and Oman as well for 2-3 days. So if anybody is nearby in the group in Dubai or Oman, just do let me know. This is my number. Save my number, and you can contact me. Please, brother, 2 minutes. Just bear 2 minutes. It's not done. 2 minutes, brother, 2 minutes. So I want to have a quick little feedback on this lecture. Quick little feedback, volunteer feedback. There are a lot of people. I don't want to give the name, but what your experience before lecture and after lecture?
Excellent talk.
Anyone? No one wants to give any feedback.
Very informative, sir. Thank you, sir, so much. Thank you so much, sir. We got to know many things in detail.
Wonderful,
We
wonderful.
can explain pathway also.
Very nice.
Very well explained.
Sir, I would like to give you feedback, sir.
Yes,
Like
please.
before the hematology, it was very difficult for me, and
Wonderful.
now with lots of simplification and the way you explain that internal pathway and external pathway, it is very clear. Right now, I understand why PT and APT the changes are happening.
Yes, yes.
Thank you so much.
No,
It's
no,
I'm really grateful to attend this session, sir. Thank you so
no,
much.
no, no. You attend the next time. Keep in touch with me or my team or backup staff, so they will guide you where would be the next session like this. Any other?
Sure, sir.
Any
It
other?
is a massive difference right now.
Yes, Yashasvi, any feedback? Yashasvi?
So I thoroughly enjoyed, sir. It has made my concepts really very clear.
Wonderful.
I'm pretty sure that I'll be joining every other lecture from now onwards.
Thank you very much. Thank you for
Thank you, sir.
boosting me up.
Thank you, sir. It was very analytical
Session was
and
very
the
informative, sir, and
concepts are clear.
hematology was very well.
No, we'll make this oncology is also very easy. This is nothing but all my experience of last 20 years, what I try to make it in a simplified way. Otherwise, there are a lot of complicated things, but I try to make things simpler so you guys better understand.
Sure, sir.
Anyone?
Thank you.
Dr. Tariq, what's your experience? If you are in lecture.
Sir, yes.
Yes, sir.
It is a very excellent. Yes, sir. It is very excellent talk given to us, and I am very afraid about the hemato-onco when you talk, Arti. But after your 13.5 hours, it's very easy for me
Very
to
nice.
understand.
Very nice.
Very good.
Very nice. Last but
Make
not
my
the least,
confidence.
Debasmita, your
You boost up my
experience?
confidence.
Sir, actually, I enjoyed the lecture a lot, and I've always dreaded hematology. But thanks to today's lecture, most of my concepts are clear now, and I can approach the question with a clearer concept. I'm also looking forward for the oncology class now.
Excellent. No, just keep in touch. Pallavi will update you like this. She did an excellent hard work, and my backup team. Thank you for all of you for joining. More questions you can post me directly. We will discuss in the group. Those who not join WhatsApp group, it's free group. You join, discuss a lot of questions that will be very important for you to crack the exam. Discussion and practice will help you a lot to crack any exam. Believe me, nothing hard. Everything is easy, but we don't understand the logic and basic. That is why it looks confusing to us. But anyway, our team, our expert, our coach, along with me, Maddie is there, Aarti is there, right? Then lot of these things are Dr. Ankit is there. So we have a nice team of coach. I'm mainly looking for internal medicine and hemato-oncology, but they are quite brilliant speakers. So you also keep in touch with Maddie and all, and stay tuned. Okay. Thank you very much all for joining. See you for the next lecture.
Thank you, sir. Thank you very much.
Take care. Bye bye.
Thank you so much.
So,
Yes, please.
hematology case. So, I would like to update the simplest way that you explained for us. And I have one more question. If you can give us for the recorded video lecture that you
Yeah,
presented.
we'll send you everywhere. Don't worry. Thank you very much.
Thank you, sir. Thank you
Thank
for
you.
the
Take care. Take care. Take care. Thank you. Take care.